colleagues, dear friends. It is indeed a pleasure to welcome you all to this 9th annual meeting of the AF Screen International Collaboration here at the historical Hallam Centre in London, UK. My name is Emma Svenberg. I'm from the Karolinska in Stockholm, Sweden, and I have the great honor of co-chairing this session together with Professor Ben Friedman from Sydney, Australia. And we have a very exciting program ahead of us today. So, without further ado, let me introduce our first speaker of the day, Professor in Neurology, Hooman Kamel, who will talk to us about atrial myopathy and stroke after Arcadia and how to assess it. A warm welcome.
Hello, everyone. I'm excited to have a chance to talk about atrial myopathy and stroke and share some recent data from our Arcadia trial and get the group's thoughts on how best to assess this concept. Before I start, here are my disclosures. And we became interested in this question of atrial myopathy and stroke because of the frequency of cryptogenic strokes or strokes that don't appear to have any determined cause, as well as observational data that we and others have found linking markers of atrial myopathy with the risk of stroke independent of atrial fibrillation. And you can see here some of these studies summarized showing links between various EKG or echocardiographic biomarkers of atrial myopathy and the risk of subsequent stroke in the absence of clinically apparent atrial fibrillation. And we also had pilot data suggesting that in patients who have elevated cardiac biomarkers such as NT-proBNP, that anticoagulation may be more effective than aspirin for preventing recurrent stroke. So based on these two things, these two sort of streams of pilot data, we made a case for a trial using anticoagulation to prevent recurrent stroke. Given the parallels between atrial myopathy and AFib, we felt like this may be a worthwhile avenue to explore. We obtained funding for the Arcadia trial, which was a multi-center biomarker-driven randomized double-blind clinical trial comparing apixaban versus aspirin. We enrolled patients who had a cryptogenic stroke or stroke of undetermined cause who also had evidence of atrial myopathy. So this was a difference between Arcadia and some of the other ongoing ESUS trials that were testing anticoagulation for preventing recurrent stroke, that we specifically selected the subset of patients with cryptogenic stroke who had evidence of atrial myopathy. The trial was funded by NIH. It was supported by BMS, Pfizer, and Roche, and it enrolled patients at almost 200 sites in the US and Canada. For our inclusion criteria, we used what we had pilot data for and what we thought were clinically practicable, scalable biomarkers. We used P-wave terminal force and EKG lead V1. EKG is very routinely done. It's simple, scalable, and we had a lot of pilot data for P-wave terminal force. We use serum NT-proBNP, again, based on pilot data and feasibility, and then left atrial diameter index greater than or equal to 3, so basically severe left atrial dilatation on echo. If patients met any of these 3 biomarker criteria after their cryptogenic stroke, they were eligible for the treatment phase of Arcadia. Starting in 2018, we consented almost 4,000 patients with cryptogenic stroke to undergo screening. Of those, 40% met the atrial cardiopathy biomarker criteria. 25% of the overall consented population ended up being randomized. Some patients who were eligible ended up not being randomized because they developed atrial fibrillation, for example, in the interim between consent and randomization. We performed the study up until December of 2022. At which time the trial was stopped by the DSMB. We had 1,015 patients randomized at that point. You can see here that most patients met the eligibility criteria either via the NT-proBNP or the EKG biomarker. And comparing the patients who were randomized to those who were screened and not randomized, you can see that our atrial cardiopathy biomarker criteria did enrich the sample somewhat towards an older group with more cardiac comorbidities and left atrial enlargement. But at the same time, there was not a lot of cardiac abnormalities in this cohort in general. Ultimately, in the primary analysis, there was no difference between groups, between the apixaban and aspirin groups. You can see here the hazard ratio was exactly 1, with the Kaplan-Meier curves right on top of each other during follow-up. We performed 7 pre-specified subgroup analyses, none of which were really, suggestive at a Bonferroni corrected p-value threshold. None of these were statistically significant. And specifically, when you look at the various biomarker criteria, there doesn't seem to be interaction between higher levels of the atrial cardiopathy criteria and a greater effect of apixaban. So in trying to interpret the neutral results of the trial, we thought maybe the biomarkers just were not good enough to detect atrial myopathy. And so we decided to look in a post-hoc analysis at the link between the biomarker levels and the risk of subsequent AFib, which we recognize as the hallmark of atrial cardiopathy. And all the biomarker criteria were associated with subsequent risk of atrial fibrillation. You can see here in the fully adjusted model, NT-proBNP was the strongest predictor. We again, in trying to interpret the results of the trial, there is a perception that perhaps the concept of atrial myopathy as a target for anticoagulation may not be over, even with the Arcadia results. That we may need to find better biomarkers of atrial cardiopathy. This was a point that was made in the accompanying editorial to our trial, and specifically pointing out that NT-proBNP is not very specific to the left atrium. And so then if that's the case, the question becomes, what is the right biomarker to identify atrial myopathy, and specifically a thrombogenic form of atrial myopathy that maybe we can target with anticoagulation or other strategies for preventing thromboembolism. And I just put these up here for food for thought. I'd love to get the group's comments. This is based on the published literature that I've seen. There are a variety of markers that have been associated with the risk of both AFib and stroke in AFib. So various EKG biomarkers, one of which we tested in Arcadia, left atrial morphology and size, MRI, determined fibrosis and flow, a strain, left atrial strain on echo. There are more specific atrium-specific natriuretic peptides, such as MR-proBNP. Perhaps we need combinations of these. Perhaps we need more advanced techniques, such as machine learning, to identify the right combination and the right thresholds of each. And I think, the possibility that we would be able to better identify atrial myopathy is still very much live. But it's challenging to study. To study this in a primary prevention setting, stroke rates are very low, even in patients with, device-detected AFib. Overall, we've seen from recent trials that the overall event rates are low. It makes it challenging to do prevention trials. In a secondary prevention setting, like in Arcadia, there's a lot of competing risks from atherosclerosis. There's a lot of very intense AFib monitoring, and if patients are found to have AFib, they're generally anticoagulated. So those are challenges. And then the other challenge that we face with Arcadia is, the specificity of biomarkers versus their scalability. So it would be great to get, fibrosis imaging with cardiac MR, but it's hard to figure out how to scale that to a trial that involves 200 sites around the country. And then there's also the fact that the less severe the atrial myopathy, perhaps there's less of a benefit, certainly less of an absolute benefit with anticoagulation compared to patients with long-standing clinically apparent atrial fibrillation. And I'm putting here the sort of results from Averroes versus Artesia versus Arcadia. Nevertheless, despite all these challenges, I think there's also a lot of opportunities. We have potential new anticoagulants being tested, such as factor XIa inhibitors. Maybe those will allow us to test these questions in larger populations more safely. There's a lot of exciting work with left atrial appendage occlusion. And either way, I think more work on atrial myopathy biomarkers will at least help us guide our AF screening and management, certainly in the post-stroke setting. So a lot of opportunities, and I look forward to working with this group to try to identify some paths forward. Thank you.
Yeah, so Taya, please go ahead.
Yes, exactly. Yeah, and so Moses is looking at MR Pro ANP, and very excited for that. But there's challenges there too. I mean, they're looking for a pretty large effect size. They also have the issue of AFib screening and how that affects the. But yes, I think that's probably a much better biomarker than. Anticoagulation. Yeah, it's DOAC versus antiplatelets. Yeah.
Yes, please go ahead.
Subgroup analysis, I noticed that there was an interaction with sex and also a trend with left atrial diameter.
Yeah.
Do you think this is this is a signal or?
No, good question. So yeah, the problem is the left atrial diameter one, it was going in the wrong direction. So that to me doesn't make any sense, I don't think. And then the one with sex, it also doesn't make sense because there was more benefit, their trend towards more benefit with men than women, but the men in the study were younger, had smaller left atria, so it's hard to see how, so we think, and once we do the Bonferroni correction that we pre-specified, it all went away. So, yeah.
Based on additives, it seems that people over the age of 75 may benefit.
Right.
Do you have any thoughts?
We were excited to look at that, but there's nothing in Arcadia, unfortunately. I mean, it makes sense that older, you would enrich for more atrial pathology in that group, but we're just not seeing it.
And you had a question?
Well, just to comment, and Human knows this, that we are doing a study in Australia using left atrial strain as the primary marker, but also embedding it in a cohort study in case we might get an answer that way. Prash Sanders is also an investigator on that study, but I hope that left atrial myopathy is still alive, but we're just using the wrong marker, and if we can get a scalable, more accurate marker, it will be better. But we'll at least have some answers to the questions because we'll also look at MR Pro ANP and some other novel biomarkers that might give us some sort of insight into what the real answer is, because we're still struggling. Even if we find AF afterwards, we'll hear later on, we're not even sure whether we should be anticoagulating them really, but there you are. It's still an open issue.
Absolutely. No, and I think strain does seem like, of all the markers, it does seem like the most promising, and it seems like it should be scalable, right? If we can demonstrate that it sort of predicts treatment effect, it should be scalable.
All right, thank you.
Go ahead.
Oh.
You freeze any blood from Arcadia?
We do have blood, and actually, if anyone has any ideas, please, because we're there. It's like there's a ton of blood samples, and Columbia, the central lab, is sort of like, we need to get rid of this stuff. So if you have ideas, please reach out. Absolutely.
Human, maybe you could speak to the challenges. I mean, is it worth another kick at it? Yes, but how do you manage the issue about the pervasiveness of consumer-facing and medical screening for AFib? So you launched another trial. There was very little effect of people being pulled off study drug due to diagnosis by other means. Is that still true today?
Well, I think that's a central challenge. Well, it's ironic, too, because when we started it, I really wanted to censor people at the time of AFib diagnosis, sort of how you did in Artesia, but we got a ton of pushback from the NIH reviewer. So we kept it as a pure intention to treat design. So I think one lesson is any future trial in the space should definitely censor people AFib. It makes no sense. We know what to do when you have clinically apparent AFib.
But even if you censor it, it's that gets rid of bias. But then, but there's still a problem, which is the patients you think might be the ones who would benefit are systematically pulled out at the time when they would start to benefit potentially.
Right.
That's an endpoint.
For me?
Just make that an endpoint.
Sure, yeah.
Yeah, it doesn't answer the question. The real question is, if you find some evidence of atrial myopathy and you use that as the main criterion for anticoagulation, is it better than aspirin? And that's the real question that I think we have to answer. And I think we're a long way away. We really don't have an answer to question whether AF detected after stroke has the same meaning as AF beforehand or clinical AF.
But maybe you can do it kind of in the middle, right? You have the standard arm, which is you get aspirin, and if you're lucky enough, you get this diagnosis somehow. Or you get an intensive monitoring strategy plus your aspirin and treatment immediately if you have the diagnosis. Again, the co-intervention thing or co-screening is
I
still.
think that's probably the most realistic way. Is
Could
just
work.
yeah. Yeah.
Thanks for the excellent presentation. I think that was the best one that I heard about atrial cardiopathy. Do you guys think that time after Ethicus and Arcadia, do you guys think that the time might have come to accept the painful truth that it's the rhythm disorder that's causing clots in the left atrial appendage? And so if no AFib, no benefit from anticoagulation, device detected AFib as in Artesia, definite benefit from anticoagulation, but...
Can you ask a question because we actually have to stop in 30 seconds?
Okay, so yeah, so do you think that's...
Yeah, look, honestly, I think practically that's where things stand right now, is that AFib is an outstanding biomarker, it seems like. If you don't have it, aspirin. If you have it, anticoagulation. That's sort of like the simplistic clinical practice. But the question is, can we do better or not? And I think that's still an open question.
For all of these sessions, we will have more questions than there are time to speak, but we have a lot of time afterwards, and so that's when a lot of the discussion will happen. So Edith and Human, I think we should discuss, we should work out what to do with blood samples, etc. So without further ado, I'm moving on. Here's the news. The next item in the news is about our links between hypertension and atrial fibrillation screening. The first paper is going to be presented by Tom Beeney. Tom Beeney is an academic general practitioner who is interested in AF screening as well as hypertension screening, but primarily hypertension screening.
Thank you. So wonderful to be here. I'm Tom Beeney, GP, a researcher at Imperial, and I'm also the lead statistician for the May Measurement Month program. I'm going to give a very brief overview of the combined blood pressure and AF screening that we've carried out since 2021. So for those of you that don't know, May Measurement Month is a pragmatic screening campaign which was initiated in 2017 by the International Society of Hypertension and is now an independent charity. And it runs annually with the aim of raising awareness of high blood pressure around the world. And the way it works is that screening sites are set up in each participating country and trained volunteers take blood pressures. And to date, over 100 countries have taken part and over 6.5 million people have been screened up to last year's campaign. We're still waiting on the numbers for this year's campaign. So you can see here are some of the countries that have been involved, and so you'll see it is a truly global campaign. Now, from 2021, we have conducted concurrent atrial fibrillation screening in a subgroup of countries. So this was initially piloted in 2021, then we had 10 countries involved in 2022, and then 14 in 23, and I'll give an overview of the results from last year. So adults, so those 18 years or over, are recruited opportunistically, and we take 3 blood pressure readings at 1-minute intervals after someone's been seated. And in 14 countries, and the list is here, concurrent AF screening was conducted using Omron Complete or M7 devices. And simultaneously, we completed questionnaire collecting demographics, use of BP lowering, and anticoagulant medication. So we've defined hypertension as we usually do in MMM, defined here. We've also used methods to impute missing data, missing BP readings, and I won't go into the details of that now. We've defined having had known atrial fibrillation, i.e. pre-existing before the date of screening, as someone who said they either had pre-existing AF or a diagnosis of an irregular heartbeat, or in people who are taking oral anticoagulants. And then for each participant, using the information that we have from the questionnaire, we calculated Chad's VASC score and define a class 1 indication for an anticoagulant as 2 or more in males and 3 or more in females, in line with the ESC guidelines. So what did we find? Well, in total, almost 60,000 people were screened in the 14 countries in 2023. The average age was about 50 years, and just over half were female. And you can see the distribution of ethnicities here. So the majority were of East or Southeast Asian ethnic groups. And overall, of the almost 60,000 people, 2% were found to have AF. So AF was detected on the screening. And of those, just under half had previously known AF. So approximately half were newly detected cases. Of those with the known AF, about half were on anticoagulants. But if we look at those who met the criteria for an anticoagulant being recommended, which is about 70% of those with known AF, then just under 2/3 were on anticoagulants. So 1/3 were untreated. And we also saw large numbers with other comorbidities, particularly hypertension. So 2/3 of those with AF detected also had hypertension, and almost 1 in 5 had diabetes, and about 1 in 6 had both diabetes and hypertension. So these are, as we know, very, very common risk factors and comorbidities. The rates of AF detection go up with age, as we might expect. So in all age groups under the age of 60, detection rates were lower than the average, but in those aged 60 or over were significantly higher. So that's a very short overview of what we found, but the highlights are that we found 2% of all individuals screened who had AF detected, with higher rates at older ages. We found particularly that hypertension was very common in AF, which I think really supports the importance of joint screening for cardiovascular risk factors. And almost half of those cases were known. On the flip side, half were unknown and newly detected, and about a third of those who were eligible for anticoagulant treatment were not taking anticoagulants. So a significant gap in terms of treatment as well. So I understand there's no time for questions now, but then we have a panel discussion, and I look forward to your questions. Thank you.
We're going to have a panel discussion, so could you hold those? The next presentation is from Teemu Niranen from Finland. Teemu is well known to those people in the hypertension area, but has also been an integral member of Effect EU. And Teemu led the recent white paper that we have submitted to circulation about 4 weeks ago, looking at the effect and the combined effect of hypertension and AF. Thank you very much, Teemu.
Yeah, thank you for the invitation. So this was a white paper that brought together the hypertension and AF communities to form a big happy family. And thanks for all the co-authors also. Many of you are in this room. So I'll just briefly go through the key points that were voted on. So key point 1, which had 95% agreement, hypertension is the leading modifiable risk factor for both AF and stroke. So key point 2, with the same percentages of agreement, so more focus, especially among those probably who are treating AF, so more focus should be placed on hypertension for prediction and prevention of AF, rather than merely as a comorbidity of AF. Key point 3, again, over 96% agreement, hypertension, AF, heart failure, stroke, and many types of dementia, so mainly vascular dementia, are part of a cardiovascular disease continuum. Number 4, we just saw results from the MMM project, so this was AF screening, but 97% agreed that positive screening for AF with an oscillometric blood pressure monitor still requires ECG confirmation afterwards. Key point 5, high-risk individuals aged 65 years or those with treatment-resistant hypertension could benefit from AF screening. So 96% agreement. And again, as you probably know from these white papers, you have to make some compromises. You try to find something new to say, but still the conclusions need to be vague enough so we can reach 85% agreement. Key point 6, antihypertensive therapy can effectively lower the risk of developing AF, particularly in patients with left ventricular dysfunction. Well, we got over 85%, 89%, a bit more disagreement here. And the final key point that reached 85% was inconsistency in the randomized controlled trial data linking blood pressure lowering with reduced AF risk likely results from differential effects of blood pressure agents on AF risk. So it seems to really matter that what type of antihypertensive is used for AF prevention. And this was the only key point that was voted on but rejected. Well, it just shows that the system works. I guess one more agree vote would have been enough to push it over 85%. However, it didn't reach it. So automated upper arm blood pressure devices with implemented technology can be used to simultaneously detect both hypertension and AF with high sensitivity and specificity. So I'm guessing the people consider that there are too many false positives to agree on this, or at least the 12 people who disagreed. Final slide, the manuscript status on the white paper. So it was submitted to circulation on June 20. Yesterday, the manuscript status was still under review after 70 days, so it's better than reject, I guess. Okay, thank you very much.
Thank you, Timo. You can stay up here and just sit. We will be having a panel discussion and talk about this, but I think it represents one of the key areas where AF Screen has thought we need to join forces with MMM. This has been a key initiative for us. It's been great to work alongside hypertension people like you and Neil Poulter, Alta Scooter, and a number of others in the MMM group. So I'd now like to call on really the sort of founder of MMM, I would guess, is Neil Poulter. Neil is extremely well known in the hypertension world and has been a president of the International Society of Hypertension and leader of this initiative of MMM, to tell us about what he thinks and what MMM thinks of combined screening and our relationship from 2024 and beyond.
Thanks very much indeed, Ben. Good afternoon, everybody. I'm just delighted to be here. As you can see, that we were slated for Ultra and I were going to give this talk in 5 minutes, and so we tossed a coin and I lost. So you've got me. The complication of that is that you get two lots of conflict of interest. Neither of us feel we have a conflict of interest. Indeed, if anybody knows a drug company that we haven't given a talk for, please put them in touch with either of us. Bit of background. Salim Yusuf said this. He gets some things right. And this is one of the things that he said, because cardiovascular disease affects a third of adults in the world, it's the largest epidemic ever known to mankind. And it's going to get worse in absolute numbers. And the biggest driver behind that, biggest risk factor, is raised blood pressure. So, a little bit of the story so far. Ben contacted us, I think, in early 2021, informally, and just said, why don't we get together? And it just seemed like a great idea to everyone in MMM. So we carried out some pilot studies in October, November of 2021 in the Philippines and Vietnam, using that device shown there. And that gave us a few ideas. It was clear from the Philippines that below the age of 60, it wasn't a very worthwhile activity in terms of the proportion that were found. And Vietnam got a quite good pickup there, so we learned from that. By 2022, we included 6 questions about atrial fibrillation or relating to atrial fibrillation in our questionnaire of 31 questions, which I'll show you in a minute. And we had 10 countries signed up to this sub-study looking at AFib. And we had 80,000 respondents in that year, of whom 1.9%, you see there 1526, 1.9% cases were detected using the AliveCor or the Omron Complete or M7 devices. And summary, the men had it more than the women. There was a greater prevalence, very similar to the one that Tom showed earlier. About a third of these detected AF cases were new, using the same definition that Tom gave you. We found that what reported as irregular heartbeat, which we included in the questionnaire, obviously because most people don't necessarily know they got atrial fibrillation, even though they've been diagnosed with that. But it was 3 times more common than the detected cases of atrial fibrillation. And anticoagulation use was far greater than we had from the AF detection rates in this sub-study. Moving on to 2023, Tom reported 14 countries, but actually a 15th country snuck in. They didn't sign up for the sub-study, but they provided the data. So we've got a bit of, there was a slight difference there, but Tom's done the right analysis on the 14 that did it a priori. And you've seen those results presented today. Here you see, I don't know if that's legible, but the ones in yellow are the ones relating to atrial fibrillation. The top one says, are you currently taking the following medications? And C was warfarin, oral anticoagulants, or blood thinners. And on the right-hand side is aspirin. Yes, no, don't know. The next one down, question 22, have you ever been experienced or been diagnosed as having, this is the irregular heartbeat thing. Then down at the bottom on the right, when the blood pressure machines recorded an irregular pulse, yes, no. The 3 blood pressures that were recorded, we recorded that as well. And then the sub-study group answered the bottom 3 questions, which were, was atrial fibrillation detected in the current assessment? And then question 32, have you ever been diagnosed as having atrial fibrillation by a health professional before? And thirdly, what devices did you use to check whether atrial fibrillation was present? So we've used those questions in 22, 23, and 24. The numbers are gradually increasing after 2020, when, because of COVID, we weren't able to do any screening at all. The update on 2023 and 2024, I'm sorry, isn't as full as I'd like to be able to give you. We had some very serious problems with some of the data in 2023, and we've had to reanalyze the whole lot globally twice. So we're now moving on to the sub-studies like the atrial fibrillation one, and we can come back and tell you more about that. 2024, the data are being collected at the moment, and you see that we had 17 countries participating this year. The 15 countries I named there included the extra one that Tom didn't quite rightly include in his analyses. So that's a background and a summary. What about the future? Well, the first thing is I think we've got to get around to publishing all the activities and the findings to date, and we're remiss. We should get on with that, and that's what we're planning to do in the next month or so. I think to make this valid, we need more information, and that means we need to get increased access to suitable blood pressure and atrial fibrillation devices, so maybe that last vote will change on the basis if we get some good enough data. But the pivotal thing is, and I think this is where we've been most remiss, is to link the AF screen activities to the MMM investigators in the collaborating countries. And we want more of both, actually, but we need to make sure that we've got enhanced feedback of what happens to the AFib we find, pass it on to the AF screen people, and then see what happens to them, and then follow them up and feed that back, that information. I think we've been remiss. We're in the process now of trying to find that out in detail, what's happening in 2023 and 2024. Longer term, out with AF screen necessarily, we plan to, I think, set up a registry of raised blood pressure around the world. It'll start in a few countries initially, but it makes sense, it seems to me, that we could also incorporate a cohort of those found to have atrial fibrillation within the MMM setup. So we've got a cohort of AF and of hypertensives going off. And finally, I think we obviously need to get into the health economic analyses of whether those activities are worthwhile. Finally, that is how doctors, that's the one on the right as you look at it, that's how they've traditionally managed hypertension. They get hold of an arm and they squeeze it, then depending on how high the mercury column goes, they dish out tablets, ignoring the object attached to the arm. And if you break the wall down, you realize that gentleman, if he's got alcohol-induced atrial fibrillation along with his badly controlled blood pressure and smoke, he's at a huge risk of stroke. If he was a she and she was taking an oral contraceptive along with those and migraine, then the stroke risk is massive. So I think it's very important we do break that wall down. And I think as part of the things, before we can hand out those tablets, whatever they are, we really need to know. And I think part of the things we need to know is not just their blood pressure, but whether they've got atrial fibrillation. Thank you for your attention.
Neil, please stay up here. And I'll ask Alta Scruther to come up. Alta was also a former president of the International Society of Hypertension and a colleague from Australia. And our task is to just talk about Quo Vadis. Where are we going now? You're the only one who hasn't spoken, and you're one of the people who are women. So would you like to have the first say?
Thanks, Ben. I think, Neil and Tom summed it up very well, but I think it's important to make sure that we expand as much as possible and maybe decide on whether to screen in MMM, at least also older age groups only, to be a bit more pragmatic and save resources. And further, I think obviously collaboration with industry and supplying more devices to ensure that we can continue on a much broader scale. And I think the most important component that Neil already mentioned is the follow-up. Same for blood pressure. We've been speaking about that a long time in MMM, is when you detect people with high blood pressure, what to do with them. We need to make sure that screening actually results in some positive outcome, that there's a treatment pathway, and the same goes for AF.
I think this is exactly the same problem that we discovered with atrial fibrillation screening, and one of the first recommendations in our first white paper was that, if you remember, Giuseppe, had to have a pathway to treatment, or to management, really, rather than treatment. And management in AF now doesn't just involve dealing out tablets. These people with both hypertension and AF require a lot of management of lifestyle and other factors. So I think that it's worth looking, continuing. I'm not quite sure of the age group, and it may differ in different countries and different ethnic groups, but a pragmatic approach is fine. But can I ask to you and to Tom and to Neil, how do we ensure a pathway, and can it be built into a program like this, which is so opportunistic?
Yeah, I think it has to be, Ben. Yeah, I think as I said, I think we've been remiss in not getting the two leads in any one country to sit together and work out exactly a route. What happens to someone that MMM says has got atrial fibrillation? They go to person X, they are seen, and the following investigations take place, and we define exactly how we're going to follow them up. What investigations will they have done? Are they treated? Yes, no. And if we get the cohort thing going, we'll be able to evaluate that as well. But I think we must do it.
I mean, one of the people in the audience, Sotras Antonio, is a pharmacy academic, and we were screening in pharmacies in the UK. But they showed, and hasn't been published yet, that if you have a route to treatment, to management, and you refer immediately to a clinic that will see the person within a couple of weeks, that you actually get much greater uptake of management that's appropriate. Tamer.
Yeah, one additional comment is what I have on the key one of the key votes that was disagreed upon. So it would be easier if we were using devices that would provide a one-lead ECG. So then we would have the confirmed diagnosis at the same time as the blood pressure reading.
Do you think that the current ESC guideline will, when it's revealed in a couple of days, will say that you need to have an ECG confirmation because that's what is in North America and has been in Europe up till now. Jeff, do you want to give us your...
It's more of a personal opinion. I still think ECG confirmation makes sense, even though the specificity of the PPG is quite good, especially in older at-risk people.
Are there any questions from the audience about what we should be doing? Giuseppe?
Excellent presentation. One question. What stage of hypertension is usually detected with this screening? Stage 1, stage 2, stage 3? I think this can add a lot to the perception of the usefulness. And according to your perception, if hypertension is detected through this screening, persistence and adherence to treatment is similar to hypertension detected in office, or maybe lower or not?
We were answering a second question. We did have some questions on adherence, and we were surprised at the answers. We thought people would be put off by the cost and the rest of it. One of the commonest answers was that people took their tablets when they felt like it. Just, if they felt a little bit down, they would take them. So we tried to get to the bottom of cost and other drivers of why they took the tablets, and there didn't seem to be much logic. And it varied around the world, obviously. The cost issue in some countries is huge. Coming to your other question, about 30% of the screened population, 6.5 million, were hypertensive, i.e. greater than 140 or greater than 90 or on antihypertensive medication, just over 30%. Of those, the people that were aware was about 60%, something like that they'd got high blood pressure. And so it's feasible, because of the one-off screening, that they didn't really have high blood pressure. We need the same sort of follow-up thing, get them, and we've had one follow-up study, sub-study done in Ethiopia, where most of them did have confirmed raised blood pressure. What sort of, well, for those who were treated, the commonest situation was that only one drug class was being used. 50-odd% were only be given one drug class, and every single guideline in the world says you should be using more than 2 drugs.
That's another issue, I think, which is really problematic about getting that to happen in, particularly in low middle income countries.
Absolutely.
So look, we have no time, but we can get one quick question, 30 seconds.
Very quick. You've got a great epidemiological study, but from that you should launch randomized controlled trials. And that design is called cohort MRCT, which you got a great opportunity to do.
Well, thank you very much indeed. We want to do it, yeah, but that's part of the getting the cohort, the registry together. Will fund that, hopefully fund that initiative to get the trials going.
Well, I'd like you to thank all of the speakers in this part of the symposium. And we can carry it on later afterwards, but I think I'm encouraged to continue the collaboration, Neil. Thank you. And I'll hand over to Emma.
Okay, so get ready. Put your gloves on. It's time for debate, and we'll start with Renate Schnabel, who will talk to us from the con side on OAC for device-detected atrial fibrillation. So welcome,
Sure.
Renate.
And could I have the talk that says Renate, because I'm supposed to battle Jeff here, and if I use his talk, my arguments might not be...
I think that would be a neat way to do it, to give one another the slides of and mix them up. Mm-hmm.
But I'm going to try to battle Jeff with his own weapons. So let's start. OAC for the device-detected atrial fibrillation, everybody, I'm on the con side. Of course not. These are my conflicts. And of course, we know that in patients with device-detected atrial fibrillation, we prefer this now over atrial high rate episodes or subclinical atrial fibrillation. This is a meta-analysis. The stroke risk is increased. We see device-detected atrial fibrillation in 20 to 30% of patients with implanted cardiac device, a huge number of individuals. And we have long-term increased stroke risk. And of course, you also know, you're here in the audience, you know that the more you search for atrial fibrillation, you longer and more intensively you look, the more you will find. If you use implantable recorders, such as the Loop study or ASSERT2, you'll find atrial fibrillation in individuals at risk in more than 30% of the patients or individuals. And what did the Loop study tell us? If you anticoagulate those with those episodes of atrial fibrillation detected by implanted device and continuous monitoring, you can slightly decrease the stroke risk, but the Loop study was not significant. And these individuals, again, they had comorbidities. Only 30% of those had a CHA2DS2-VASc score of 2. All the other patients had a much higher CHA2DS2-VASc score. Average was 4. So we would say higher risk individuals for stroke systemic embolism. And you see here again, this is just side information that only in those with very high blood pressure and controlled high blood pressure, this study was significant and appeared to provide a benefit if you anticoagulated atrial fibrillation detected by a loop recorder. And this is, I like this image very much, Ben Friedman developed in 2018, and it clearly shows where the problem is. That if you do a very short period of monitoring, single time point, we'll catch atrial fibrillation that is probably higher burden than the atrial fibrillation we will detect using a continuous monitoring, and Ben calculated it, 31 million seconds per year versus a single lead ECG 30 seconds handheld device. And of course, stroke risk is inversely related. So we have Artesia and we have NOAA AFNET6, and you see the stroke rates on aspirin 1.24% per year. This is not 2% like a CHA2DS2-VASc score of 2 where you should anticoagulate patients. Or in NOAA, we must say a study that was stopped early due to futility, the stroke rate was 1.1% per year. So this is far away from the 2% in the CHA2DS2-VASc score. So 1% you can talk to your patient on whether you want to get anticoagulation or not. But not necessarily everybody should be anticoagulated. And this is mirrored in older data, which shows that if you have atrial fibrillation detected by a device, but if you have limited comorbidities, here the CHA2DS2-VASc score is used, and even if you then, lower panel, lower panel here, I can show it to you, but if you have no CHA2DS2-VASc 0 or 1 on the CHA2DS2-VASc score, even if you have longer episodes, your risk of stroke is comparatively low, under 1% per year. And therefore, my conclusion would be device-detected atrial fibrillation is common. There is a low risk of stroke or systemic embolism, lower than we expected until we got the evidence from Artesia and NOAA AFNET6. If I think in terms of guidelines, we have one large, well-powered study, Artesia study, that shows a potential benefit, but this cannot necessarily be a 1A recommendation to anticoagulate everybody with device-detected atrial fibrillation. However, I would see it as an opportunity for risk factor treatment and follow-up for clinical atrial fibrillation, and possibly an optimal selection of patients who might benefit from oral anticoagulation may be key. So, OAC for device-detected AF in all? Certainly not.
Thank you so much, Renata. And here to respond now on the pro side, we have Jeff Healy.
Well, I can't beat the certainly not. That has a nice inflection that almost convinced me, but I'll stick with the data where I can be most effective. So here we go. So here are the issues. So should we, as I see this debate, should we treat some of these patients with device-detected atrial fibrillation? And the answer to all these is yes, by the way. Should guidelines recommend oral anticoagulant for specific patients. And these are based on three kind of suppositions. One is that the stroke risk is sufficiently high and the threshold somewhere between 1% and 2%. It's curious that Renata's own slide, that nice graph with the blue section, shows the 1% cutoff for significance. And somewhere along the way, we've kind of upped that. But again, dial back the clock to when Greg and others were hatching CHADS VASC out of CHADS, and the logic for that was that, you know, the CHADS 1 group was 1.9% per year stroke, and that was deemed to be too high to forego anticoagulation. And as I recall, and Greg can confirm this, CHADS VASC distilled out a group with less than 1%, and that was why it took off. So somewhere along the way, we've kind of migrated to see that 1% is not really important anymore, but I think much of what we have suggests it is. Second question is, does anticoagulation reduce the risk of stroke? And I think the data are quite clear it does. And is the bleeding risk acceptable? And I will show you my views on that. So we know that device-detected atrial fibrillation is lower risk. We've known that for about 15 years. There is the CHADS specific rates, because that's what we had back in the day. No subclinical AFib in blue, subclinical AFib in white, and then clinical AF in orange. And interestingly, when you go up the CHADS VASC scale and file this for future reference, you see that the difference between the no SCAF and the SCAF actually becomes a lot more pronounced when the CHADS goes up. CHADS VASC would do the same. So it is lower risk, should not surprise us. The fact that anticoagulants cause bleeding should not surprise us either. So Artesia, that was the design, and these are the results. So that aspirin rate of around 1.24% per year, it's lower than expected. And again, don't make the mistake of taking these results as indicating what happens in real life. Okay, so this is a clinical trial where 25% of people got pulled out the minute they developed long episodes and started an open label anticoagulants. If you think you do that in real life, think again, because that's not what happens. It's not what happened in TRENDS or in ASSERT. We didn't pull patients out because, if you believe Isabel Van Gelder's paper, this is when the risk in ASSERT seemed to go up, and we're taking them out of the study, off the drug, and putting them there. So keep in mind that this is a trial data with internally valid results. Stroke was indeed reduced. It was reduced by 37%. It was significant. These are smaller numbers, right? The absolute risk is only about 0.5% per year. Interestingly, however, there was no signal on hemorrhagic stroke, and it was the big strokes, the Rankin 3 to 6, you know, the ones that cause permanent disability or death, that was reduced by about half, and these represented somewhere around 40 or 45% of all the strokes. So you're preventing a lot of big strokes. Yes, you did increase bleeding. The intention to treat, it's about a 0.4% per year incremental bleeding, which is significant as well. However, as opposed to the big strokes, 3 to 6, the bleeding largely resolved with conservative or supportive measures alone. Very little in terms of fatal bleeding. And in fact, if we go back here, you can see that fatal, actually I don't have it on the slide, but I'll tell you that fatal bleeding was no difference in between aspirin and apixaban in Artesia. So that's the data. I think it's pretty clear there is a reduction in stroke, albeit smaller in terms of absolute terms. Now, the results are consistent. This is the meta-analysis that we jointly did between NOAA and Artesia. The effect on the NOAA outcome as well as stroke or systemic embolism are both in favor of treating in terms of relative reduction in risk, with a very consistent effect between the two studies. Now, how do you distill it out? Again, CHADS VASC, here's the distribution of patients. So most people in Artesia had a CHADS VASC of 3 or 4, with fewer patients with the higher scores. But you can see that distribution. And when you look at the results of the study broken down by CHADS VASC, and I'll draw you to this last column, looking at absolute risk reductions, you can see that stroke and embolism in that CHADS VASC greater than 4 group is reduced by about 4% absolute. Whereas in the CHADS equal to 4, about 2.25%, and then in that lowest CHADS group less than 4, there's no real effect. And the bleeding, however, on the other hand, tends to be consistent. So bigger bang for your buck in terms of absolute stroke reduction. To show it graphically, there's the CHADS greater than 4, so stroke and systemic embolism goes down from about 8% down to 4%. You can see major bleeding goes non-significantly up. The CHADS less than 4, you see the reverse. There's absolutely no benefit there with an increase in major bleeding, also non-significant. And then the equal to 4, lower risk, but still some benefit here. So when you look at this in a number needed to treat over 3.5 years to prevent stroke, and it's actually should be stroke or embolism, you can see for less than 4, it's a ridiculously large number of patients you would need to treat. For CHADS equal to 4, it's about 44 patients treated for 3.5 years, and for the greater than 4, it's 25 patients treated for 3.5 years. And you can see the corresponding bleeding rates there. So I think CHADS-VASc works pretty well. Not all the factors are equal. Here is the stroke data, so we have a lot of neurologists in the room. You can see here in the patients with a history of stroke or systemic embolism who were underrepresented in both of these trials because we all thought that they should be treated and did not enroll as many as we could have. You can see here high risk of about 10% risk of stroke on aspirin within 3 years. It goes down by 6.2%, so that's an NNT of 16 in the patients with prior stroke or TIA for reduction in stroke. Lastly, what didn't work, burden didn't seem to work. And again, the caveat here is the burden range between about 0.1% and 1% for the patients in this trial. So it's a really small range of burden. When you look at it, longer episodes compared to shorter episodes, there really wasn't any difference in the rate of stroke moving forward in the aspirin arm. If anything, the stroke rate was a little bit higher for shorter episodes, and the treatment effect was no different statistically. Again, the treatment effect tended to be better for the short episodes rather than long episodes. These are the data that Bill presented at the European Heart Rhythm Society. So, to conclude, I think it is clear that anticoagulation prevents stroke in patients with device-detected atrial fibrillation, and with very simple subgroups like CHADS-VASc, you can identify those with a much higher rate, so greater than 2% per year stroke and embolism rate. And I think those patients are where the attention should be focused. So I agree with that point, that we can use clinical tools to risk stratify who we treat and who we don't treat. But I think it's important that CHADS-VASc is nicely distinguished between those who could and couldn't benefit. And you're going to see a lot more data coming up here in the coming days at this meeting. Prior stroke seems particularly important. Atrial fibrillation burden, at least within that restricted band, does not. And we're going to see papers come out on age and vascular disease, and Lena's going to present a paper on cognitive function. The other part that's not in this, right, is about a quarter of these patients went on to develop clinical AF and artesia. And so, that is also important. If you don't believe this story, there's going to be a large number who progress. But I'll just come to the last part. I think the guidelines do need to be updated. I think we have to have commonality between clinical and device-detected atrial fibrillation. So we can't have a different threshold and number in terms of percent per year stroke rate between the two. That would make no sense. But we could have different cutoffs in terms of things like CHADS-VASc, for example. And I think that would make for nice harmonized guidelines. And I think, at some point there are good data here that we could give some clear guidance for particular subgroups. I agree that not for overall. I don't think that's clear, but I think for some of these subgroups, prior stroke, for example, 3% stroke rate goes down by half. That's a pretty good benefit to be had. So I think we do answer yes to all those questions, and we'll leave it for the panel here. Thanks.
Thank you, Jeff. And we're looking forward to hearing John's summation now of these two battles. Please.
Thank you very much, Emma. Good afternoon, everybody. I'm giving this talk on behalf of Wolfram Dörner, who recently ran an international collaboration assessing the value of atrial fibrillation burden. And he wanted this talk to center on that issue. And so that's what I'm going to talk about briefly this afternoon. First of all, I think all of you will recognize that AF burden is simply a measure of the amount of atrial fibrillation. But it has been measured in many different ways, from, for example, the total duration of atrial fibrillation in any monitoring period, but without any concept of a denominator, the number of days in which atrial fibrillation appears, the number of days in which more than a certain amount of atrial fibrillation appears. So there are many different measures of atrial fibrillation burden. The working group concluded that in patients with intermittent atrial fibrillation, AF burden is a measure of the amount of AF during a specified monitoring period. AF burden is defined as the proportion of time in AF expressed as a percentage during a specified monitoring period, but further, the longest period of uninterrupted AF, which is often described as LEAF, the acronym, within a specified monitoring period should also be reported expressed as a time duration. So this illustration describes those features. At the top, we see for this month-long period the blue areas of atrial fibrillation and the white areas no atrial fibrillation. It's easy to calculate the total duration of atrial fibrillation as a percentage of time. If we look at the second scheme, you can see that the longest period of atrial fibrillation, or LEAF, is illustrated on that part. And if we look at the bottom part, we can see that the number of days, in this case with AF more than 6 hours, is used as a calculation for AF burden. The problem, of course, is that unless you are using continuous monitoring, there are great difficulties in using, in particular, the LEAF estimate of burden. You can see the top two panels here, a continuous recording, but of course physicians may interact. They may terminate the atrial fibrillation, or the patient may be treated with, for example, a pill in the pocket, and he may terminate the atrial fibrillation, and therefore we do not get an accurate assessment of LEAF even with continuous monitoring. But if we use intermittent monitoring, for example, just 4 periods of continuous monitoring, you can see that the estimation of the longest episode can be distorted by the recording of AF being seen at the end of the recording or the beginning of the recording. You can see also with patch monitoring that we'll have periods where the patch is disconnected. We'll have periods where there is too much noise to estimate the burden correctly. And of course, burden is not a simple static measurement. It will progress, it generally does progress. And along with the progression of atrial fibrillation will be a progression of underlying cardiovascular or systemic diseases, which themselves will also represent a risk, for example, for the development of adverse outcomes associated with atrial fibrillation. So in a way, the progression of burden and the progression of underlying disease complicate the issue. We've already seen part of this slide before. It comes from the ESC guidelines issued in 2020. On the left, however, I want to remind you that atrial fibrillation burden does progress. If you look at the baseline recordings, the longer the baseline recording of or burden of atrial fibrillation, the more likely it is to progress to even higher burden. And on the right hand, of course, you can see that there are at least 2 dimensions to risk of stroke in this particular instance, both the AF burden and the underlying cardiovascular risk. Now, it's probable that there are not only 2 dimensions to consider in risk, but multiple dimensions. And we've heard, for example, this afternoon of the left atrial dimension. So there are many potential dimensions that we have to consider in addition to the AF burden. Now, recently, we've had this publication from Rod Passman's group, and you can see here that we do have an estimate of stroke or death in a 3-year follow-up according to burden. These are quintiles of burden, and you can see that the highest quintile, some 29% stroke or death at 3 years, and with the lowest quintile, i.e. 0, AF 10.8%. And we can also see that atrial fibrillation does progress in terms of the burden. If we take all comers, a follow-up decrease of burden is associated with decreased hazard, and an increased burden with increased hazard. We can see that patients who had no AF to begin with and then develop AF have a hazard ratio of 1.87 for stroke or death. And if, on the other hand, they had all AF and that decreases, any decrease, then the hazard ratio will fall to 0.78 for the group as a whole. If we look at the various publications relating to burden and stroke, we'll see that very many of them use the leaf estimate rather than the percentage of time in atrial fibrillation. Not all, but very many of them. And we are now beginning to see that there is some correspondence between the leaf estimate and the AF burden as a percentage of time. For example, in this study by Derek Chu, you can see how with the maximum duration, there is an estimate in all-cause mortality, which hazard ratio increases as the maximum duration increases. You see similarly with the percentage of AF burden, and we see also that ischemic stroke increases. Now, I want to also show you this study from Dominic Lentz and his colleagues in Maastricht, looking at post-operative atrial fibrillation. They've recently published that there is a correspondence in this particular population between overall POAF burden and the longest episode duration. So that, as you see, a fairly tight correlation between the two. And you can see also that the likelihood of recurrence of atrial fibrillation is much greater if the initial POAF burden is higher. We also therefore can begin to try and address whether there is a consensus on an AF burden cut point after these trials. And I think that the answer must be that there is not any particular consensus, at least not yet. But I think the problem is asking for a cut point, because I think there is no single cut point that we can attempt to find. And if we abandon the concept of cut point and consider burden as a continuing variable and add it to the risk from other dimensions, then I think that we will have a reasonable estimate of risk. Thank you.
We'll get them at the end just to save time a little bit and the schedule.
Want me to introduce?
Dominic, Nick?
Yes. Okay, I'd like to introduce now Dominic Lentz. In fact, he was the senior author on the last two papers mentioned from Maastricht. And Dominic's going to tell us about the AI, ML, and AF screening update. So thank you very much, Dominic.
Yes, Ben, thank you very much, and also for the opportunity, of course, to talk here on artificial intelligence and AF screening, so an update. We have seen this already quite a lot, and we know, of course, that at the moment, mainly the entrance point into AF screening programs is mainly based on age. But of course, we want to be better. We want to actually understand better who have a higher risk to develop atrial fibrillation and who might benefit from anticoagulation. And exactly there, artificial intelligence might add to what we currently use as an entrance point into AF screening programs. So artificial intelligence is actually a tool more or less to find something what we can visually maybe not detect at the moment out of data sources. If we think about different data sources, particularly in cardiology, the ECG might be one widely available data source, of course, for this use. The ECG is rich in physiological information and represents an interesting input, therefore, for artificial intelligence algorithms. And if we actually think about different applications already of, for example, ECG-based AI approaches, detection of atrial fibrillation is certainly one of the first real-world implementations already. We see this a lot also in atrial fibrillation screening programs. How does this actually work? We actually know that ECG is not just based on a 12-lead ECG, but also on ECGs actually provided by different variables. We can think a lot about a lot of different variables. Some of them actually have ECG, some also have PPG. We already have heard that PPG is not able to detect or to diagnose atrial fibrillation, but I think particularly in AF screening, detecting something which is most likely atrial fibrillation is still very, very helpful. So we should actually not close our eyes and actually ignore PPG signals for screening. No, we should actually integrate this and then actually just accept that at the moment still ECG documentation and actually confirmation of AF is needed. Artificial intelligence algorithms are included in ECG diagnosis and also PPG diagnosis. The sensitivity and specificity of those algorithms are actually very, very good. But the problem is they are not perfect. And once actually you have a big cohort, which you actually screen, a sensitivity of 0.96 might actually not be good enough, because still you actually might overtreat or undertreat, depending on how you actually see it, quite a lot of patients. So we have to realize this. What I also think is that atrial fibrillation, and particularly in the setting of atrial fibrillation screening, AI might also be helpful to actually identify patients who might develop atrial fibrillation in the future. So detecting incident AF and sinus rhythm, this actually has been particularly investigated by the Mayo groups. Here actually a study where mainly 12-lead ECGs were used and a big cohort of patients who were in sinus rhythm at the time point when actually this ECG was taken. And then during follow-up, some of those patients actually developed, some others did not actually show atrial fibrillation in this cohort. And you can see here that with a very good sensitivity and specificity, AI algorithms can actually identify those patients during sinus rhythm which might develop atrial fibrillation afterwards. So already an ECG during sinus rhythm might be very, very helpful. There's been also a follow-up study. It was a prospective, but importantly non-randomized intervention trial. And you can see here in red, for example, those patients with a high risk AI-enabled ECG versus actually patients with a lower risk based on the AI-enabled ECG information on the bottom. And you can see that the likelihood of actually detecting atrial fibrillation afterwards is much higher in the group where the sinus rhythm ECG already showed actually that the risk of atrial fibrillation might be higher based on the AI results with an odds ratio of 4.9. Interestingly, in this prospective non-randomized intervention trial, they also tried to implement and incorporate some clinical risk markers, but they actually were not able to actually identify their subgroup versus actually standard of care approaches afterwards. So AI-enabled ECG in sinus rhythm may be used to identify individuals that can benefit from prolonged screening for paroxysmal atrial fibrillation. So if you actually have a high risk based on the sinus rhythm AI-enabled ECG, this might actually provide you a subgroup of patients where it is more likely to potentially find atrial fibrillation afterwards. It's not just possible with a 12-lead ECG. Emma actually also showed that potentially also single-lead ECGs might be effective for this use. Atrial fibrillation is actually the one, of course, what we want to identify based on the AI-enabled ECG. But the question is, of course, what is now actually detected by this AI algorithm? I will not go too much into detail here, but the hypothesis is that AI-enabled ECG predicting AF directly relates to the presence of underlying left atrial myopathy. You can see here a study with, from the left to the right, here on the bottom, here on the bottom actually, you can see that based on the AI-enabled ECG results with higher risk developing AF versus lower risk of developing AF, left atrial volume index, left atrial reservoir strain decreased, and also changes in the index ratio actually was present. So the higher the risk based on the AI-enabled ECG is, the more likely you also have echo-derived markers of atrial myopathy. The interesting thing is that combining AI-enabled ECG might also be combined with other risk factors, but also risk markers, and their multimodal AI approaches have been introduced. You can here see, for example, out of different studies, that if you combine, for example, the AI-enabled ECG algorithm with risk factors, here in dark red, you can actually increase the likelihood of actually finding atrial fibrillation afterwards in those subgroups. So the incidence of atrial fibrillation increases if you actually combine them. So in AI-enabled ECG and clinical risk factor models, for example, the CHART-AF score and others, are complementary and can be combined in those algorithms. When we actually now come back to the different stages, when we actually screen for atrial fibrillation, we first have the entrance point, of course. It's not just age, but potentially also in combination with biomarkers, but also AI-enabled ECG can actually help there to identify target groups where it is more likely to find atrial fibrillation. And something which is actually already present at the moment is, of course, the real-world implementation to increase the efficacy and also the speed of atrial fibrillation diagnosis in the big number of ECGs which are provided, and their AI can be used. So I would like to summarize that artificial intelligence may enhance conventional screening strategies, real life implementation, by just actually increasing efficacy and speed of AF diagnosis. This is something what we already see. What might come is to identify target groups for further screening, AI-enabled ECG to predict incident AF and sinus rhythm ECGs, and combination of this with different risk factors, CHART-AF and AF and others. And we are still quite early, of course. So we need much bigger data. We also need confirmation of what we have seen in those non-randomized settings. And we particularly also need support for real-world implementation, collaboration with industry, and so on. Thank you.
Dominic, we're already 6 minutes over time, not because of you, and I wanted to thank you very much for your presentation.
Thank you.
If anyone wants to speak to Dominic, just remember where he is, what he is. There will be the opportunity during afternoon tea and also during the networking session afterwards. It'll be the same for my session. I don't need to introduce myself, but I need to apologise on behalf of Rod Passman, who was unable to attend, and he's asked me to present his talk on consumer-facing devices for AF. Whether they're helpful or unhelpful was the title, but in fact he rewrote it as helpful or harmful. So initially I'd like to show something that was by Emma Svenberg, showing that there are many different ways to do it through PPG and ECG. I don't really need to go through this in this audience. But mostly the digital devices that are facing consumers are either PPG or ECG based. The cases for wearable rhythms, again from Emma Svenberg's Europace article, showing that on the left-hand side you can see we've got screening in atrial fibrillation in the general population. They can be used there. Or you can have in people who have known atrial fibrillation, looking at maintenance of sinus rhythm, burden, rate control, all those things can be used that are consumer-facing devices. These facing devices normally used by consumers can be used by health professionals. The benefits and risks of screening we've got, they can prevent stroke with anticoagulation, they can prevent atrial remodeling if we know what to do, prevent tachycardia-induced cardiomyopathy, and they could reduce AF-related morbidity, hospitalization, or mortality. But of course, the risk is that if we find low-burden AF that may not cause stroke and expose the patients to risk of treatment with anticoagulation, there can be misinterpretation and erroneous diagnosis, overdiagnosis, and overtreatment. And you may detect other abnormalities when you find something that lead to tests and treatments that cause harm, and the pathway can be uncertain. Well, again, remember that we've got provider-led screening in general with these devices, but the devices on the right, consumer-led screening, can be used by health professionals and are increasingly being done for that purpose. Screening using handheld digital health has been done over the years. Digital AF, Search AF, Rehearse AF, and Vital AF. Most, except for Vital AF, showed an increase in AF detection with the using the handheld, but this is by healthcare professionals. And then we've got Stroke Stop and Zenicor Stroke Stop 2, which will be presented at this meeting, and the iPhone or smartphone eBrave AF, which also found that you can use these consumer-type facing devices with healthcare supervision to get an increased AF detection rate. In MUFA 2, led by Utah Gual, one of our members, and Greg Lipp has been an advisor to this group, they used the wristband technology to not only detect the AF, but to have an app that was used by consumers to help their management program. And so this is another potential useful approach with consumer-facing devices. The Heartline study is another that's ongoing using Apple Watches, and here they are doing a study which is randomized, looking at outcomes of AF diagnosis, AF treatment and stroke, and heart failure and death, so multiple endpoints. And you've got those people with no history of AF and non-watch wearers, and some of them are provided with watches, and then they're randomized. And this study will be reporting, I think, in a year or two. Then we have the various studies which have shown that these devices can give, these are the smartwatch devices, can give an assessment of AF presence as a screening tool, or in patients who have known AF, can be used by health professionals to assess the burden. And these algorithms, when we're trying to assess the burden, are set to favor sensitivity, because we already know the patient has the diagnosis. Whereas in the general population, we reset the algorithm to favor specificity, so we don't get false positive diagnoses and have to then investigate lots in a population approach. So one size doesn't fit all. We've heard about the relationship of CHA2DS2-VASc score and AF burden, which interact to give you the risk. But Rod Passman is particularly interested in whether we can stop oral anticoagulants if we monitor intensively with a pill-in-the-pocket approach, which would minimize the exposure to oral anticoagulant while maintaining stroke prevention. This was the motivation behind his digital health and AF management, React AF pill-in-the-pocket approach, where the patients, mostly who've had an ablation, which is deemed successful, are given a watch. They're on anticoagulants, and they're asked to monitor themselves. If they develop atrial fibrillation detected by the smartwatch, they can record an electrocardiogram, which, if it shows atrial fibrillation, they can recommence their anticoagulants, and if it doesn't show anticoagulation for a month, they just stay off their pill. So that's the React AF trial, randomized 1-to-1, chronic NOAC, watch-guided targeted NOAC, and the primary endpoint non-inferiority is all stroke and arterial embolism and all-cause mortality. Secondary endpoint for superiority is major bleeds. They are proposing to randomize over 5,000 patients in 50 to 100 sites, follow-up for 3 to 5 years. It's funded by the NIH, and enrollment has started last year. But of course, I added these 2 slides, which Rod agreed to. A cautionary tale published just in last month in JAHA. And you see the title, Wearable Devices, Healthcare Use, Psychological Wellbeing in Patients with Atrial Fibrillation. First author is Lindsay Rosman. These were the conclusions, and they did very, very sophisticated psychological tests in people, non-randomized, but those who were wearing the smart watches, largely. Higher rates of symptom monitoring, preoccupation with symptoms, or preoccupation with rhythm. AF-specific healthcare use was increased. Use of informal healthcare resources was increased. And the AF treatment concerns were more common. So it's not all, they were really not all good. Wearables were associated with higher rates of symptom monitoring and preoccupation, AF treatment concerns, AF-specific healthcare use, and use of informal healthcare resources. And we need, that was their conclusion, we need prospective randomized trials to see the net effects. The editorial, wearable devices and psychological well-being, are we overthinking it? So we can't assume that we're always doing the right thing. And of course, different people react differently. One man's fish is another man's poisson. So to answer the question, consumer-facing devices for AF, helpful or harmful? Yes. I thank Rod Passman.
Thank you so much, Ben. And we now move on to our final speaker of this session, emerging leader of the World Heart Federation, Jamil Ahmad, who will talk to us about screening for valvular atrial fibrillation in rheumatic heart disease in Africa, the AFRESH trial.
Unfortunately, it's going to be Diana Fu.
Sorry.
Because Jamil was unable to come due to not being able to get a visa to this country after about 4 weeks of request. So instead, it will be presented by one of his colleagues who attended the Emerging Leaders meeting of the World Heart Federation, Diana Fu from Malaysia, from Sarawak. And there are a number of other emerging leaders here who have all become AF Screen members, and I'm really pleased to have this great diversity of people from different parts of the world who are emerging leaders in heart health. Thank you very much, Diana.
Thank you very much. Good day, ladies and gentlemen, dear colleagues and friends. So without further ado, I'll just go along with our AFRESH trial. This trial was created last year in October in Sydney by the 8 of us. It leveraged on the use of digital health technologies for home-based atrial fibrillation screening in RHD patients. So Jamil, who stood on the second, on the right in the picture, champions this study currently in Nigeria in LMICS, one of the LMICS, as the principal investigator for this study. RHD is a leading global health problem, especially in LMICS. 1 in every 3 patients with RHD had AF. And in fact, the incidence of AF increases close to 3-fold every 5 years within the first 10 years after the initial diagnosis of RHD. In sub-Saharan Africa, AF is reported in 20 to 35% of individuals with RHD. In Nigeria, the prevalence of RHD ranges from 2.5 to 38.5 per 100,000 from various registries, with an incidence of AF of approximately 25.8%. despite such high incidence of AF in individuals with RHD, most guidelines do not provide recommendations clearly on how and when to screen for AF. And therefore, the main objective of our study is to assess acceptability and feasibility of a home-based atrial fibrillation digital screening using a handheld ECG device in patients with RHD. Besides that, other objectives include evaluating impact of study intervention, estimating the detection rate of atrial fibrillation in this high-risk population. The AFRESH study is a multi-center, single-arm, prospective, pragmatic, mixed method feasibility study of a home-based screening program for AF in patients with RHD in Nigeria. This study involves 4 sites, 3 in Kano State and 1 in Jigawa State in the northern part of Nigeria. And to give you a better idea about these 2 states, Kano State is about the size of Slovenia, except its population, it's 7 times much more compared to the population of Slovenia. Jigawa State is about the size of Tuscany region in Italy, except its population is about twice as much than that of Tuscany region. In Kano State, there are 13 cardiologists in total looking after not only 15.5 million local population, but also patients coming from neighboring states in the northern part of Nigeria, as well as the neighboring countries across sub-Saharan Africa, including Niger Republic, Chad, and Cameroon. In Jigawa State, there are total 4 cardiologists, 2 adults, 2 pediatrics, looking after 7.5 million local population. All these cardiologists in Kano State and Jigawa State are all based in urban area, which means there completely no access to cardiologist service in rural areas. This limited access, I believe, is typical not only in Nigeria, but across many LMICs. The key inclusion criteria included prior diagnosis of RHD and at least 1 risk-enhancing criteria, which is recommended in the 2021 APHRS guidance on AF screening in RHD. This is the only guidelines we found that included the recommended criteria for AF screening in RHD patients, which is based on a significant valvular heart disease, heart age more than 50 years, left atrial diameter of more than 40, and NYHA class 2 or higher. After exploring various ECG devices, we've selected the Zenico handheld ECG device, which we believe is pragmatic in the settings across the LMICs. Now, Zenico handheld device is a single lead thumb ECG with excellent sensitivity and specificity. It uses the AA batteries, which means it does not need recharging. So this is pragmatic in settings with poor power supply. And secondly, it does not need any smartphones to use the device. So this is pragmatic in populations with high digital illiteracy. Besides, it is easy to use. The ECG, the device recorded intermittent ECGs using the finger sensor, which means to record an ECG, the patient only has to place the fingers, both thumbs, on the device itself for 30 seconds. And then the devices either transmits ECG tracings by wireless to the cloud database, or if the internet connectivity is not available, or if it's when it's offline, the device is able to store up to 230 seconds ECG recordings. So in this study, the device is either picked up at home by the site personnel and retrieve the ECG recordings, or the tracing is being transmitted wirelessly. So patients are able to perform the recordings by themselves or with assistance from family members. So the patients who are eligible are provided with tutorial on handheld ECG device before collecting the device home for a participant-initiated home-based ECG recordings for 4 weeks. 30 seconds ECG tracings each time, 2 times a day, and if symptoms occur. The site personnel will contact the participants routinely once a week by phone calls or text messages. And if the poor quality threshold has been reached or there's no ECG tracings received, site personnel will review the ECG tracings received daily during the weekdays. And if AF is detected, the site personnel will contact participants and clinicians to reassess the ECGs and initiate the necessary treatment. If no AF detected, the participant will continue the ECG recording. Upon device return, the ECGs will be retrieved from the device if necessary. Cardiologists will review ECG tracings and initiate treatment if necessary. Questionnaire and semi-structured interview will be conducted. So the data collection is collected. To assess the feasibility, the number of interpretable ECG strips obtained at 4 weeks will be collected. And besides that, all the others, including questionnaires, semi-structured interviews, are all the typical feasibility and acceptability framework. So we expect to enroll at least 50 patients, with at least 10 also participating for the qualitative analysis, and we expect to interview 5 healthcare workers who are involved in this study. The AF detection rate will be compared using the historical cohort groups with descriptive analysis. The MRC process evaluation framework is applied in this study, which results in future implications, particularly in advocating the use of digital home-based screening for AF with modifications and guide and pragmatic evaluation based on the ELMIC context. At the moment, we've obtained ethical clearance. We are in the process of arranging for a digital, for the Zenico device procurement. And our policy review abstract is just accepted and will be presented at the APHRS Congress coming. So additionally from this study, we'll also plan to consider other AFib researches, which include the use of AI-powered ECG device for AF screening in the underserved rural sub-Saharan African community, as well as the genomic epidemiology of AF among stroke patients in the sub-Saharan population. So we are starting our study pretty soon, and hopefully by the next year, this time next year, we're looking forward to present more results. Thank you.
Thank you very much, Diana. I really want to congratulate you and your colleagues, some of whom are in the audience. I think 2 in the audience, or 3 from that group, who are doing something. We're all very much concerned about non-valvular atrial fibrillation in high-income countries, and we forget about the high incidence of rheumatic heart disease in low-income countries and middle-income countries, and the devastating effect of AF in that condition. So I really congratulate you. I wanted to thank Zenico for their assistance with the devices, because it can work in an area where you have little internet support, and it could be feasible to have this more widespread within Africa. So I think this is a great initiative from World Heart Federation Emerging Leaders. Thank you. Well, this brings me to the pleasant request to you to all get yourselves refreshed. We've heard of Afresh. This is Refresh, and we have afternoon tea break between now 3:30 and 4. You're welcome to bring any afternoon tea back into this room to your table and continue discussions. Thank you very much.
Not enough time.
Almost.
Welcome back, everyone. Before we start our next session, I'd like to invite you to think about what we will work on for the coming 12 months. We have had a very successful publishing experience from AF Screen. Each year we publish 1 or 2 manuscripts. Most, if not all, have been in circulation. And the process is usually that we ask at this meeting for ideas for publishing activity for the following year. And we also mention to you that there will be a general invitation for members who are interested in that particular topic and who are prepared to contribute actively to that particular topic to be authors on the manuscript that we eventually produce. So the question at the moment is simply, what shall we consider for the coming year? And we have had already a few ideas that have been put forward. Could I have the next slide, please? These topics, you can just skim through them. Device-detected AF through a broader device lens, implantables and wearables, provoked triggered secondary AF, and the emphasis there would be on what monitoring is necessary following AF due to a transient cause, after the transient cause has been managed. Screening for AF specifically in athletes. Targeted screening with multimodal or multidimensional risk as part of that. AF management strategies for various populations with AF detected by screening. The detection and management of AF in heart failure, particularly HFpEF, and an update on the paper on cardiac monitoring post-stroke. Those are ideas that have been transmitted to the executive committee so far, but we're interested in any ideas that you would like to briefly mention now, or if you wish, you could let the executive committee, by emailing Ben or myself or anybody that you can see on the rostrum, with your ideas, and we'll try and put together some activity for the following year. So does anyone have any particular comment that they would like to raise?
I think the HFpEF is very topical. And there is an area where there are some good knowledge.
So you're for HFpEF and AF? think it's a preference.
A good one. Any other ideas quickly?
Yes, please. A microphone coming up to you.
Just wait, so wondering about prevention of AF. We're likely to be detecting more and more AF that we don't want to anticoagulate, and it's thinking about alternative things that might be done, despite what Jeff was saying a few minutes ago.
Preventing AF, yes.
Yeah, preventing clinical AF is not a bad thing.
Yes, please.
I was going to suggest to evaluate the role of AF burden in predicting strokes and other outcomes, and there might be different AF burden cutoffs for different outcomes, like stroke, dementia, heart failure. There is some data, as you alluded to earlier.
Thank you. Yes, Chris.
Something along the lines of pre-AF, again, depending on what comes out in the guidelines in the next few days.
Yeah.
So when you've got negatively screened high-risk AF patients, what is the pre-AF phenotype? What are the outcomes? How can we challenge it?
Any other ideas? Yes, please.
I'm wondering if the role of AI would be interested in all of this, and in particular, going beyond potentially looking at the AF only for burden and a couple of well-known metrics, but really letting an algorithm potentially doing a better prediction in certain aspects.
I think that's a very good idea also. It could fit into the targeted screening.
Yeah, target.
Yes, please.
The detection and management of AF in Indigenous peoples.
AF in Indigenous people. Thank you. Yes, please.
One of the point is, for me, is the treatment of patient with asymptomatic AF, because actually we have some data to treat early these patients, but we are not enough data. So maybe a consensus on this point on how treated this could be interesting to have.
Thank you.
Thank you.
I think we've probably spent enough time on this for the moment, but if you have other ideas, please let us know. We'll try and make our decisions within the next month or 6 weeks, and we will then be letting all the members of AF Screen know about the manuscripts that we might like to develop, and you can then decide whether or not you would like to contribute and can contribute and will contribute. I emphasize that because joining these manuscripts is not just to add your name to a list of authors, but it is to work on the manuscript.
Hear, hear.
With that, I think we can start our next session, and it's going to start with Ben, who you all know, and he's going to tell us some of the highlights of the 23-24 sessions.
Thank you very much, John. So 23-24 year in review. I'm very pleased that we have 8 commercial sponsors, more device than pharma. We have TMA, who was with us last year, Heart Research Institute and HRI UK, and this year, for the first time, the Arrhythmia Alliance and Atrial Fibrillation Association helping out with getting this venue and very capably in assisting us to manage the meeting and the Heart Research for managing this meeting. This is the largest meeting so far, 66 members registered, and even more at the industry round table, some of whom are with us now for the afternoon session. So a big year. A personal note, I'm alive. I was not able to be at this meeting last year. I survived a reasonably large intracerebral hemorrhage. Virtually unscathed now, amazingly. Back to full-time work and with you again, alive and kicking. So does make you appreciate prevention of stroke. It also is very helpful for grants where you need to have people with lived experience. This is a very, very extreme way of getting lived experience, I can assure you. So what happened this year? Well, as you all know, Artesia Noah were published. We have a new term, DDAF, Device Detected AF. I like it much better than REs or SCAF. Jeff and Paulus both agree on this one. The thing that struck me was that there was a lower stroke risk than we had thought, but I think that shouldn't have been too surprising. The expected bleeding risk offsets the gain, and sub-studies show us some subgroups at best risk-benefit ratio. So I think that's been a great change this year, and we will see even more when we get the individual patient data meta-analyses through. At ESC this year, there will be a number of follow-ups on the aspirin indication in NOAA from Renata Schnabel, on age and Artesia from Marco Proietti, and on cognitive decline, Artesia, Lena Rivard. All of these AF screen members. We had Arcadia presented and published. You heard about it earlier from Human Kamel. Although it was a neutral result for atrial cardiomyopathy, it's not the last word. I mentioned earlier in this meeting AIMS, the Australian study of which Mark Parsons and I are leading, Moses study by Mira Katan, MR Pro ANP. And the strength of our group is that we have 4 stroke neurologists attending today. So if you have a stroke, you're in a good place. AF screen, Affect-EU completed. Renata, you got the €6 million grant. It was extremely successful exercise and has funded the individual patient data meta-analysis. I think this is a fantastic exercise. We'll hear a bit more about those. We will hear at Stroke Stop, at ESC, we'll hear Stroke Stop 2 being presented and GUARD AF presented. I think we will have all of those in the individual patient data meta-analysis. We will also hear at ESC on Sunday, September 1, the Miracle AF study presented by Chen Min Long, Mingfang Li. Mingfang, are you here in the audience? Can you stand up? I just went to see this group present, or at least show me what they were doing. Greg Lipp has been a very important advisor for them, but they showed me what they were doing in Jiangsu province, in Taizhou. It is called a Miracle AF study. It is really a miracle AF study. I encourage you to see it. It's really something very unusual and very interesting. At ASC this year, we'll see the new AF guidelines of Europe. Isabel van Gelder and Deepa Katica leading that. And we had the AHA ACC guidelines. We'll see how similar they are. This year, our hypertension and AF white paper, you heard the key points and that they've been submitted. And the early AF white paper led by Emma and John has been voted on. And you will hear about the key points which were all accepted, and it's ready to go to circulation. The consensus on AF burden, led by Wolfram Dörner and John Cam, and half of the people who are contributors there, or a bit more than half, were members of AF Screen. It's ready to be submitted somewhere. This year we have new members. I'm really pleased to welcome people from the World HUD Federation Emerging Leaders Program. I wonder if you could stand up for us, because you saw Diana Fu, and we've got Frank Nziza from Burundi, and we also had Jess Orchard, and she's gone. Elizabeth? No? Okay. and Liz Peratz from Melbourne. So, but we had a very diverse group of young people who are not so young, but not so old. And they're all emerging leaders, and they've become members of AF Screen and devised that incredible study, very much needed, that will happen in Nigeria to screen for valvular AF. And there are a number of other people here who are attending the very first meeting who are members. Can you stand up? Don't be shy. Put your hands up. Welcome to AF Screen. It's a pleasure to have you here. There's no subscription fees. It's only pleasure when you come and join. So, I want to thank you, to the steering committee, to the executive, all of the members, for a very diverse and vibrant community. And I also want to thank our sponsors, our industry sponsors, without whom we couldn't have these meetings. And I want to thank especially the Arrhythmia Alliance and Trudy Laban for helping us to run this meeting. Thank you very much.
Thank you very much, Ben. We can now move to one of the neurologists that Ben mentioned. Delighted to invite Luciana Spasato, who's the head of the stroke unit and professor of neurology in the other London, London, Ontario, to the delightful weather in this London, which is very strange. You have much better weather in the other London, but thank you very much for attending, and you're going to talk about AF detected after stroke.
Thank you. Thanks very much, Professor Kam. So, yeah, these are my disclosures, and I'm going to try to, I know there are lots of cardiologists here, so I'm going to try to speak from the neurologist mindset, right? So I wanted to feel how we feel when we see patients with stroke and atrial fibrillation. The first concept is that depending on when AFib is detected in relation to when stroke happens, there is a difference in terms of clinical characteristics and stroke risk and stroke recurrent risk. So what we can see here is that AFib can be diagnosed before stroke onset, and that's what we call known AF. It can be diagnosed in the first ECG after the patient is admitted or when they come to the emerge, and in that case, it's around 7 to 8% of all the cases of AFib that we find. And then we can use short-term monitoring with 14 or 48 hours of Holter or less than 7 days. And then on top of that, we can add 14 days, 30 days, or even an implantable loop recorder. And the more we monitor, the lower the burden of AFib and the lower the risk of stroke. That's the main concept. So just for you to have an idea of what stroke neurologists are doing in 2023, this is a survey among 200 stroke neurologists. And I'm sorry that I'm going to show some data that are not published yet, but I thought it would be interesting for you to see this. So among 200 neurologists from 58 countries, you can see that the proportion of use of different cardiac monitors, it's quite striking. In patients with all types of strokes, cryptogenic and non-cryptogenic, we can see that most of the neurologists use for 24 to 48 hours of Holter monitoring, no more than that. There is a low proportion with 14 days, and then there is a 0.5% that use implantable loop recorders. So outside the USA, we can say that implantable loop recorders are practically not used. If we look at cryptogenic strokes, we can see that the proportion of medium-term monitoring going from 14 days to 30 days increases, but still there is a very low proportion with implantable loop recorders. So this is just to see how relevant it is when we talk about implantable loop recorders in patients with stroke. So what determines stroke risk in patients with stroke and atrial fibrillation? As you know very clearly, risk factors, which also determine the presence of atrial substrate and AFib burden. And when we put all that together, when the three of them act together, we have a higher risk of stroke. So what happens when we compare patients with AFib known before stroke onset and on the other group, AFib detected after stroke onset. So the first thing that we can say based on multiple meta-analysis of multiple studies is that the presence or prevalence of risk factors and cardiovascular comorbidities is much lower and significantly lower in patients with AFib detected after stroke compared to AFib known before stroke onset. Overall, they have a much lower risk profile with a very significantly lower CHA2DS2-VASc score when we put all those factors together. The other one is that the left atrial size, on average, is smaller in patients with AFib detected after stroke, which means that they have a lower degree of atrial substrate. And what happens with AFib burden? So in that part, I'm going to go a little bit slower, and I'm going to show you what we found in patients with implantable loop recorders. You can see here 3 very distinctive patterns. The first 2 ones that are labeled under A show that some patients have a really high burden of AFib. And in some cases, it's just triggered or it just happens after stroke onset. In other cases, it's present before stroke onset. The problem for us is that we don't know if it existed before or not. We just find that they have a very high burden, and there's no question in those cases we need to use anticoagulants. There is another pattern in which AFib occurs a few months or sometimes years after the stroke in very short-lasted paroxysms that are very random, and they're not related to the prior stroke or any stroke recurrences. It just happens, as it may happen in many of us along our lives. It's a very benign paroxysmal atrial fibrillation. And then there is a third pattern that happens immediately after stroke onset, in the first week or maybe in the first hours, which is probably what we call neurogenic AFib, in which the AFib is triggered by autonomic or inflammatory mechanisms. And you can see there the frequency of each of those patterns. So in implantable loop recorders, we can say that at least there is a huge heterogeneity in terms of the types of atrial fibrillation that we can find as stroke neurologists. And what happens in patients with short-term monitoring, with 14 days of Holter monitoring? And you can see here on the left side of your screen the burden of AFib that we found in 14-day Holters in 137 patients or so. Overall, the median duration is 5.2 hours in 14 days, so it's pretty low. And only 19% or so have a higher proportion, have a duration larger or longer than 24 hours. So overall, even on 14-day Holters, these patients have a very low burden. So to summarize, patients with atrial fibrillation detected after stroke have a lower burden of AFib, have a lower prevalence of risk factors, a lower prevalence of comorbidities, and a healthier heart overall, with a better ejection fraction of the left ventricle and smaller left atrium. Left atrium. So what happens when we add a 4 factor here, which is time? Because what we are seeing as stroke neurologists is a picture. It's a picture at the time of stroke onset, but we don't know how things are going to evolve in the next few years. So this is a more recent analysis in which we compared patients with known AF or AF known before stroke onset. You can see there are 385 cases. We had another group of patients with AFib detected on an ECG on the first day of admission or at the emergency department, and then a third group in which we detected AFib on 14-day Holters. And you can see here that there is a significant difference in terms of stroke recurrence in patients with AFib detected in 14-day Holters. They have a much lower recurrence rate. But the important thing is that when analyzing this in terms of time variation of risk, there is a variation in the relationship between AFib detected on ECGs and known AF before stroke onset. At some point, at 1 year, they have the same risk. But that does not happen with 14-day Holter detected AFib. It never changes. It doesn't change in 3 years. It remains very low with a very low recurrence rate. And all 3 groups have 80% of anticoagulation rate. So what I'm trying to say here is that the risk of stroke recurrence in patients with AFib is time varying, at least for ECG-detected AFib compared to non-AF, and that's probably because they're quite similar. They were not detected just because they were asymptomatic before the stroke. For those who have 14-day Holter detected AFib, the issue might be that we need 5, 10, or 15 years of monitoring to see if they become, if their AFib burden progresses, if they have more risk factors, and if simply the age is the one that drives the risk of stroke. We've heard very interesting results from NOAA and Artesia, and I just wanted to point out a few differences here that make me think that we cannot extrapolate those results to the patients that we see in the acute phase. For example, if you look at the CHASVA score of the populations, the one in the middle, the one that says London Stroke Registry, is the London from Canada. We serve a 2 million population, and it's almost a population-based registry. And you can see there that overall the CHASVA score of patients with 14-day Holters is 4 compared to 6 in NOAA and Artesia. The other thing is that in NOAA and Artesia, we don't know when they had the strokes, right? So if they had their strokes 4 or 5 years ago, the burden of risk factors, their age, and other conditions that may predispose those patients to have strokes may have evolved. Whereas in patients with acute stroke, we are seeing just at the moment in which we are detecting the AFib. So they are very different populations, and I don't think we can say that we can use anticoagulants for every single patient in which we find SCAF or device-detected AFib. We need to consider the time factor when we make those decisions. And finally, just to review the future of AFib detected after stroke in patients that undergo prolonged cardiac monitoring based on the results of Artesia and NOAA. In my view, and this is my personal view, we cannot say that that ILRs should be used for every stroke patient. We don't have evidence from any of these studies that that's the way to go. Additionally, I don't think the one-size-fits-all for all patients treated with anticoagulants if they have device-detected AFib after a stroke is correct. We need, for you cardiologists, it's easier because if you just ask the patient, have you ever had a stroke 5, 6 years ago? That's fine. Anticoagulants might be better. But if they had a recent stroke, the risk of having an intracranial hemorrhage or having another stroke because of other mechanisms such as carotid disease is much larger. So we need to be sure that we're treating the right mechanism before we jump into atrial fibrillation. And then finally, we need to acknowledge that we are dealing with very different populations from real life. We need to keep that in mind because what we have seen in those trials, the population of those trials is not the same that we are treating in our real life. So overall, I think we need to follow the path of the 4S-AF scheme in which it is important to consider not only AF burden, but also risk factors, age, demographics, and put everything together, combine it, and then identify which patients are at higher risk of stroke. And that's what we have proposed for specifically for stroke patients, a bad risk AFDAS approach, in which we, as CHASVASC evolve throughout time, we need to be sure that we acknowledge that AFib burden, risk factors, age, and other variables will increase throughout time. Some patients will reach the threshold at which they can have a stroke. Some others will never reach that threshold. And ideally, we should do a more precise kind of medicine and identify who receives anticoagulants and who should not receive anticoagulants in their entire life. Thank you.
Thank you very much, Luciano. A very nice update on post-stroke or AFDAS in your talk. I think in the interest of time, we need to move on, although there are a lot of discussion points you raised. And I would now like to call to the podium Larissa Fabritz, also from Hamburg. And you'll tell us a little bit about predicting high risk in low-burden atrial fibrillation. And you will focus on your biomarker studies you did over the last years. Larissa.
Yeah, thank you, Renate, dear chairs, dear colleagues. Yeah, I was asked to shed light on a biomarker study that we published this year at Frontiers meeting. And I think biomarkers can give us a chance of connecting known disease mechanisms of atrial fibrillation and the patient's management. There has been a disconnect in between these, a very frustrating one. Maybe the new guidelines will come up with more connections, hopefully. But circulating biomolecules, or that can be used as biomarkers, are quantifiable proxies for disease processes in patients with atrial fibrillation. And in the Catch Me Consortium, which was a European consortium on atrial fibrillation, we collected 15 or 13, 14, 15 different biomarkers with metabolic or inflammation or fibrosis or other potential ways of creating the atrial fibrillation process. And some of them are known to you, like NT-proBNP or troponin, and some of them are novel but had patents, so we could work with companies to measure them all at the same time and in high precision. And as a derivation cohort, we were able to use the East-AFNIT4 biomolecule study. The primary outcome of the study was a composite of death from cardiovascular causes, stroke, or hospitalization with worsening of heart failure or acute coronary syndrome. And all patients had a blood draw at baseline of biomarkers and were then randomized, but this was just here about the biomarkers and the primary endpoint. And you could argue maybe that East-AFNIT4 is a study with relatively low atrial fibrillation burden because all these patients were known to have AF, but just within the first year of diagnosis they were included, and there were a lot of paroxysmal AF patients in there. We then did unsupervised clustering of patients based on biomolecules using latent class analysis, using polytomous variable latent class analysis. It's called POLCAR. So it's an unsupervised learning, groups of set of objects similar to each other but different from other groups are grouped. You can do this with cheddar or other cheeses, or with biomolecules. So this was really totally agnostic to the clinical data otherwise. And so when we quantified the biomolecules in the patients, there were 4 biomolecule-defined patient clusters. And we did a couple of tests to see whether these were optimal clusters. So these 4 were pretty clear. We had to look at these 4 in dominance and commonality analysis, and looked at the biomolecules that mostly explained these. So in the first one, there were a lot of low values. Then there was one where some were up and some were down, and some where most of them were up. And if we looked at the clinical characteristics, you could see that in the one where most biomarkers were down, this was a low disease burden, few comorbidities, something you would expect. Then here in the green, these were the least obese patients, but they often had valvular disease. And there was no inflammation, but some of the biomarkers like BMP10, NT-proBNP, and angiopoietin-2 were just slightly elevated, but nothing was terribly elevated. In the orange ones, there were more males. They had a higher BMI, and some of them were quite obese, and there was a lot of inflammation in the biomarkers we see here, like IL-6 and CRP. But other biomarkers like BMP10 or NT-proBNP were not that high. And in the red here, there was more heart failure and chronic kidney disease. A lot of biomarkers were up. We then looked if these correlated with the cardiovascular events in each biomolecule cluster. So with the primary outcome of EAST, which is the combined outcome of cardiovascular events, you can see here that the high-risk cluster actually has a 5-time higher risk as a low-risk cluster over the years. We then did an independent validation in another cohort. This is the BBC-AF cohort. It's a cohort of patients coming to a hospital in Birmingham, some with sinus rhythm, some with AF. We only took the patients with AF in this case, and used the same biomolecules and tried the same clusters. And they also spontaneously clustered into 4 clusters. And again here, although the risk overall is higher in this cohort, again, the highest risk cluster is 5 times as high as the lowest risk cluster. And some of the biomarkers we looked a little bit closer in other studies. Some in the room might have been involved in those as well. So, for example, biomarkers predict risk of recurrent atrial fibrillation in the AXAFA-AFNIT-5 trial. That was a trial with ablation, and the recurrence was predicted by NT-proBNP, angiopoietin-2, and BMP10, so bone morphogenetic protein 10. And others have also been very active. For example, the Uppsala group has seen that BMP10 predicts ischemic stroke risk in atrial fibrillations, even if they are all anticoagulated. So we think it might be worth looking at biomarkers further. So in this unsupervised analysis of biomolecules, could define clusters of patients with AF with unique patterns. And importantly, between biomarker clusters, there's a 5-fold gradient in risk of cardiovascular events, and this was confirmed in an external validation. So biomarkers emerged for prediction of atrial fibrillation recurrence and stroke, and for predictive value of biomarker on sinus rhythm at midtime follow-up. If you're interested, please come to the AF hotline session in Cairo on Saturday. I will speak after Giuseppe. And there we will also talk about the clinical characteristics and not just the clusters. Thank you. I would like to thank the group. And thank you for your attention. Yeah.
Thank you very much, Larissa. Are there any urgent questions? A quick question. Larissa, just one thing, you put in 13 biomarkers or so, and then finally the clusters were only defined by 2, 3 biomarkers. What about the other biomarkers? Were they also in those clusters somehow, but you did not show them? Did they also?
Yeah, I kind of showed the top biomarkers that were important for this cluster, but in a way there's a model. You can see how which biomarkers work most for the model. And apart from the 3 that I already mentioned, also EGFBP7 was very much working. There were like 5 biomarkers that were used a lot, and you could reduce to N of 5 and still get the same outcome. So you don't have to do all these biomarkers. But maybe if there's no doctor, but you're able to do a blood test, a couple of these biomarkers could tell you a lot.
Thank you very much.
Thank you.
And now I would like to introduce Prash Sanders. Prash, you will answer the question, can modern comorbidity management reduce stroke? I would say yes, but you have to show us how.
That's a classic. Thanks, Renata, and thanks for having me here at this meeting. So putting this together, I was looking at the comorbidities in terms of stroke, and this is a neat study that's just been in press from the University of Minnesota, where they've looked at all of the risk factors and tried to grade them in terms of what the meta-analyses have shown in terms of risk of having a stroke. And they're kind of listed here, and atrial fibrillation is also in the stroke literature considered one of those comorbidities that they consider. So it gives you an idea of what we have in the literature already. They then take this a step further, where they look at the population attributable fraction for first stroke. So these are people who've had first stroke. It's in a US database, and they look at what the attributable risk is. And I think a few things stand out here. It's that obesity is number 1 on this list. Hypertension is number 2, and you can put it in perspective in terms of where atrial fibrillation is, although most of these risk factors actually give rise to atrial fibrillation as well. And so that gives you a little bit of perspective in terms of what risk factors need to be targeted. They then looked at an analysis where they said, let's look at trying to reduce 20% of these risk factors in the community to see how many strokes can be prevented, and they've given an estimate of the stroke prevention that can occur as a result of managing these risk factors. And so based on these ones, you're talking about 37,000 strokes, first strokes, per year in the United States by a 20% reduction in these risk factors. So that kind of gives you a perspective as to why we need to be considering this area in terms of a possibility of harder outcomes for our patients. Now, to bring it back to atrial fibrillation, in the AHA guidelines, we put this figure in talking about the spectrum of AF disease, acknowledging what we're talking about in terms of screening to detect early atrial fibrillation. And when the one unifying treatment that we had for the whole thing here was to treat modifiable risk factors from the first onset of AF, pre-AF, through to more permanent atrial fibrillation. And so we need to look at that in that perspective. Our group has been working on comprehensive treatment of risk factors for patients with atrial fibrillation, and we've looked at all modifiable risk factors on the premise that this is a condition that's caused by a number of conditions, and that by treating each of these risk factors we may be able to improve outcome. And so this slide shows a number of those comorbidities that we can treat with the kind of targets that we're using to treat these patients too. And many of these have been discussed extensively in a variety of meetings. We've shown a number of studies, and the one I want to highlight is this one from Melissa Middledorp, which looks at reversing the AF process. So shown on this slide is where the risk factor of weight, but as a measure of overall risk factor management. And if you don't manage your risk factors, you have a progression of disease over a 5-year period. And this is seen in the green, where 48% of people progress from paroxysmal to more persistent forms of atrial fibrillation. But I think the other is more interesting, that if you manage your risk factors and you get at least 10% of weight loss together with your other risk factors, 88% go from persistent to either paroxysmal or no atrial fibrillation. And so it gives us an idea that we may be able to change disease course, at least for atrial fibrillation, and hence the reason to consider the risk factor management. Now, I want to show you some data that's being presented by Rajiv Pathak at the upcoming APHRS meeting. This is in a randomized study where we looked at randomizing patients over a 12-month period to see what can occur, and I want to bring it back into the stroke context. So here's the sort of risk factor change that we can achieve. There's significant reduction in weight, blood pressures improve more dramatically, with less antihypertensive because the weight's gone, sleep apnea improves, diabetic control and insulin resistance improves, cholesterol improves in the group shown in orange, and more people reduce their alcohol consumption and stop smoking as a result of this kind of intensive program to try and change each risk factor that the person has. Now, where does it get interesting? It gets interesting in terms of what sort of structural change we get. And so left atrial volume related to stroke risk significantly reduces as you manage people's risk factors. LV septal size due to hypertension control improves in this population, and features of diastolic dysfunction improve as a result of managing risk factors. If we look at cardiac MRI, LV mass reduces, epicardial fat reduces significantly in this population. And then it gets even more interesting, because if we look at circulating fibrotic markers, they are improved significantly by managing risk factors. Now, if we think of stroke risk in terms of AF, Virchow's triad in terms of forming thrombus, we're also seeing improvement in many components of that. Endothelial function in terms of circulating endothelial markers markedly improved as a result of risk factor management. Platelet activation significantly improves with managing risk factors. And inflammatory markers are also markedly improved. So if you put this in context, not only are risk factors going away as you manage the weight and manage their risk factors, but we're also seeing hard endpoints in terms of circulating markers that would reduce the risk of stroke, or at least be associated with reducing the risk of stroke. We have not yet shown that this has an impact on mortality or stroke at this point of time. Now, there is also data that says that if we look at the essential, Life Essential 8 as put out by the AHA, on the people who've managed that versus who have not managed that, there is data to say that the group that's managing this well have a lower risk of stroke, a 48% lower risk of stroke. And so it's very suggestive that we ought to be looking at comorbidity management for stroke prevention. And I guess in terms of modern day, you know, what's happening with their GLP-1 receptor agonists and weight reduction and the substantial improvement in health that results, we don't have any direct comparison here. So this is kind of pooled data from large studies, mainly in diabetics. But what it does come out with is a 17% reduction in all stroke, 16% reduction in non-fatal stroke, and a 20% reduction in fatal stroke. So it's very suggestive that this is an important target for us in terms of preventing stroke. So while we still wait for the ESC guidelines to be published, this is from the AHA guidelines. We did put modifiable risk factors as a central pillar for the management of atrial fibrillation. I want to highlight the base of this house. We did introduce what we published earlier in the year, is to start looking at the patient from head to toe in terms of the risk factors that they may have, modifiable risk factors that can be treated to try and prevent AF and perhaps prevent stroke in the future. So thank you.
Thank you very much for this overview. And I think we would move on immediately to AF detection early in disease course. And as you've already heard and have participated, many of you in the paper here on this topic, I would like to ask Emma first to answer the question, why should we do it?
So thank you very much, Renata, and thank you to all of you actually for letting me have the privilege of leading this paper together with John. And first of all, our first question really for this paper was that we called it the early paper. And then we started really to think about what sort of terms should we use to encompass this. And our discussions were so long-winded, I think, that John actually made a slide on how we should define this. So let me now show you the different terms that we discussed for this paper. The first one was acute onset. So should we use that? But then perhaps that's more AF occurring abruptly and provoking medical intervention. We didn't think that was exactly spot on. So should we use then the term early AF? And then we saw that, you know, the new American guidelines, they actually used the term early onset for AF that occurred before the age of 45. So that wasn't really what we were after in this paper. So how about first onset then? And we thought about that for a while as well, but then we figured that, well, this is more like AF occurring without any history, and we can't base the temporal classification. So finally, we settled on the term recent onset atrial fibrillation, and that's AF then occurring within 1 year from any documented AF or symptoms suggestive of previous AF. And I think this will actually lead to a publication, John, by you on AF terms, right? So in the end, we chose to name our paper then Treatment of Recent Onset Atrial Fibrillation. And many of you know this, and you're in this room. We were 57 co-authors. And it says that it's submitted to circulation. It's almost submitted. We just need one more little letter, and then we are done with the first step. So why then did we choose to do this paper? Why did we think this would be interesting for our group? Well, this is the key illustration of this paper, and I think it well highlights the three things we thought about. First of all, how we have come a long way in trying to diagnose and detect atrial fibrillation. So novel strides have been made in trying to find atrial fibrillation early, both by prediction, using AI, for example, novel prediction models. And we also have, of course, a lot of new tools for AF detection. Second, we also have a lot of new treatment options, not only DOACs, of course, but we do also have novel ablation techniques, and we also have more treatment based on comorbidities that Prash just discussed. Finally, we also thought about outcomes. In the past, we only discussed about stroke as an outcome, but in this paper, we wanted to recognize that there are many types of outcomes for patients with recent onset atrial fibrillation that should be discussed. AF burden, AF progression, but also dementia, cognitive impairment, anxiety, quality of life, heart failure, hospitalization, and costs, of course. So this was the rationale behind the paper, and I'll just deep dive a little bit into these different steps. So first of all, improved prediction. We heard a lot today from Dominic's talk about the use of AI. This is implemented already in the Mayo Clinic, so this is actually one of their epic screens where you can go to the screen after you've taken an ECG and you can find out various things from the AI model, the age of your patient, the probability of their being male, which seems to vary a little bit if you look at the graph, but okay. And then also, of course, the probability of them getting silent or them having atrial fibrillation in the future. And indeed, in this patient, atrial fibrillation was detected on an ECG a few months later. We also have a lot of new tools to detect atrial fibrillation, and this is just a compilation of studies having screened for atrial fibrillation. And we can see, for example, using more continuous monitoring, using a patch, we detect 5% in an elderly population, handheld ECGs intermittently for 2 weeks, as in the stroke stop studies, about 3% new AF. Intermittent ECG recordings twice weekly for a year, as in the rehearsed trial, identified 3.8%. And then we have PPG detected atrial fibrillation in the eBrave trial, identifying 2.4%. Now, of course, compared to device-detected atrial fibrillation, these numbers are quite a lot lower. We also now have a lot of consumer-based diagnosis. And in this paper, we recognize that indeed there are opportunities with having consumer-based detection of atrial fibrillation, such as getting an earlier detection, earlier treatment, consumer empowerment, but also some challenges. When it comes to treatment opportunities for atrial fibrillation. Now, this is sort of the journey of many patients with atrial fibrillation. As time goes by, you get older, you get more comorbidities, and you sort of shift from being perhaps at risk for atrial fibrillation to entering a more preclinical stage, and then finally getting clinical atrial fibrillation. And recent onset atrial fibrillation spans some of these features. And what are really the treatment opportunities here? Well, I think Prash just mentioned very nicely in this talk that, of course, here we can manage the underlying cardiovascular pathology and the adverse lifestyle of these patients. But also for recent atrial fibrillation, oral anticoagulants and early rhythm control are treatment options. Now, these treatment options can also be used to try to limit progression of atrial fibrillation that we know is common, 7% progression per year in these patients, and the mechanism going from more focal ectopic firing to a more re-entry prone substrate. And I think John will address this more in his talk soon. I also wanted to highlight other treatment opportunities in our patients with recent onset atrial fibrillation. And this is data by Greg Lipp's group, and it's a Korean database. And what they did look at here is in patient with really recent onset atrial fibrillation, treatment with either just early rhythm control or with healthy lifestyle factors could reduce the risk of stroke, about equally actually. But if you combine the two, you could see that the risk of stroke was really substantially impacted. So here's really a treatment opportunity for our patients with recent onset atrial fibrillation. How about outcomes then? Well, we wanted to discuss different outcomes, and I've grouped them a little bit together. So we have stroke and dementia and heart failure, sort of hard clinical outcomes. But we also have things that factor a lot for the patients: anxiety, their quality of life, also for decision makers, the amount of hospitalization, the costs of patients, and also finally, with regards to AF disease in itself, the burden and also the progression, and I'm sure there are several more. From all of these discussions, we came up with some key points. And thank you all for voting. We had more than 90% agreement on the votes. And the key points were on definition of recent onset atrial fibrillation. So the first one was recent onset atrial fibrillation can be defined as newly documented atrial fibrillation and a history consistent with AF for no longer than 1 year. Then we went on to discuss how this could be revealed and in whom it could occur and how it was likely to progress and what could be suggested as treatment and in whom. The most discussed point was this key point 7 that was discussed a lot in the author group prior to sending it out for a vote. And I sent out an email to all of those who had comments about key point 7, and then I went for a family dinner. And when I came back and looked at my email, there were like, I don't know how many emails actually on this topic. So there was a really long discussion prior to coming to this conclusion. But in the end, many of you agreed on this key point 7. And then we had effective treatment on underlying cardiovascular conditions and also management of risk factors, including lifestyle modification and why we would do it. So with that, I'd like to thank you very much for all of your interest and your debates and discussions in trying to write this paper on recent onset atrial fibrillation. So thank you.
Thank you. So John, you will now tell us what additional data are needed and how we can get there.
Thank you very much, Renata. I'm sorry to trouble you by speaking yet again, but I'd like to set the scene by suggesting to you that in almost every area of medicine, the sooner you treat a condition, the better the effectiveness of the treatment, which is in stark contrast to how guidelines managed atrial fibrillation. We had to wait for symptoms, and when symptoms occurred, we had to offer rate control and definitive management, rhythm control of atrial fibrillation, and management of comorbidity was hardly mentioned. And therefore I think it's very important, because recent onset atrial fibrillation offers an early opportunity to manage the condition, that we consider whether we do have the data to support that in terms of how it will assist the underlying cardiovascular disease or lifestyle, how it will affect longer-term outcomes. So if we just, for example, look at this slide, In the middle, we have recent onset atrial fibrillation. Now, this population is probably slightly different to the traditional population. It's a younger population, and usually the AF, of course, is less established, and underlying or comorbidities are usually less established. What gives rise to this population is that atrial fibrillation is being looked for by screening. It's been recognized as a problem when it's provoked by transient causes. It's detected on implantable devices and wearable devices. And of course, it's detected often incidentally when patients are assessed for surgery, when they have insurance medicals, or when they have occupational health assessments. What we have to consider, I think, is if we do have the opportunity to treat recent onset atrial fibrillation, can we forget about requiring symptoms? Can we forget about the rate control issue? And should we go to rhythm control to manage the atrial fibrillation at a much earlier stage? Will that lead to a reduction in the adverse outcomes associated with atrial fibrillation than it would if we left it until it was more established and the cardiovascular disease that surrounded it was also more established? Now, of course, we need to know a great deal before we can really take that step. We do not know, for example, what these populations are like. We don't know when we should intervene. Should we intervene simply because we've recognized the AF, or do we have to wait for some indication of recurrence or some indication of progression of the atrial fibrillation, or can we wade straight in with simply recognition of atrial fibrillation? What kind of intervention should we offer? And will better rhythm control be achieved? And will that better rhythm control reduce the adverse outcomes? Of course, we were all alerted to so-called early rhythm control by trials like EAST-AFNet-4. You'll recall that the average or median time from AF diagnosis to getting into this trial was only some 36 days. And we know that contrary to other rate versus rhythm control trials, there was a positive outcome in favor of rhythm control, and specifically CV death and stroke were reduced. This was supported quite quickly by a number of registry-based studies, this one again coming from the Korean database, and Greg published this, and we see that those who had early rhythm control compared with rate control did well, but there was little difference between rhythm control and rate control when patients began the rhythm control more than 1 year following the diagnosis. So this strongly suggested that early rhythm control would be more successful than later rhythm control. We know from studies, for example, that of Derek Chu, that a catheter ablation less than 1 year after the diagnosis was more successful at reducing the recurrence of atrial fibrillation than if the ablation was delayed. But on the other hand, we know from John Kalman's study that randomizing patients to a delay or an immediate ablation made very little difference to the recurrence of atrial fibrillation. We also have data looking at larger groups and cohorts of patients that dealing with rhythm control early is much more successful than leaving it later. So statements such as the shorter the better in terms of the data to the treatment time was more successful. We also know from even larger studies that AF recurrence and first cause hospitalization, for example, are much better if we treat the atrial fibrillation earlier with rhythm control. And finally, this study was just published again from the Korean database, looking at patients who had a stroke. And these strokes were generally quite severe strokes, and they were divided into those who had early rhythm control within 1 year, and those who had who were treated in a non-rhythm control manner. And you can see that the bottom line that there was a 28% improvement in terms of outcome if the patients were treated earlier. So in summary, I think that patients with recent onset atrial fibrillation that specifically identify recent onset must be more fully characterized. We have lots of clues that earlier treatment is better, but most of the data is just comparing early rhythm control with usual care. We have very few randomized trials, and most of the studies are simply observational or registry-based studies. And there are even fewer trials that deal exclusively with recent onset atrial fibrillation. The main question is, will early rhythm control of recent onset AF lead to a reduction in adverse cardiovascular outcomes? And we simply do not know that in many circumstances at present. Thank you.
Thank you. Is there a short comment or question, Taya?
I don't think I'm proposing that.
True. So, and you're saying we don't know. So how are you proposing that we know when we all think it's true?
What do you think is true?
That early rhythm control delays progression and adverse outcomes.
Depends on the type of arrhythmia, I think. If you see a patient with paroxysmal atrial, I don't think it's always true. If you meet a patient who has paroxysmal atrial fibrillation, short episodes, that might be true. But I'm not sure whether putting this kind of a patient on a class 1C antiarrhythmic drug or a class 3 antiarrhythmic drug will improve outcome versus putting him on diltiazem or a beta blocker. And if you have a patient with persistent atrial fibrillation, it's even less known, I think, because we have a lot of trials in the past which show that it doesn't matter. So I'm not sure why you think it's true.
I think there's lots of evidence that earlier treatment of paroxysmal atrial fibrillation will actually delay the progression of the atrial fibrillation. What we don't know is what the long-term outcome effects are. And that's what we like to find out. We have clues from registry data that look very good. And the question is, how can we do this more definitively in order to persuade guidelines to change their mind? I think they're going to change their mind anyway, but not on the basis of controlled randomized trials.
Okay, one more quick question, please.
Yeah, thank you very much. Alan Cameron, a stroke physician from Glasgow. It will be a very quick question. Recently conducted an online survey of stroke physicians looking at their opinions of management of AF post-stroke, and rhythm control was an area in which anxieties were identified from stroke physicians and how to manage. Do you think if we were to adopt such an approach, do we need tools to support stroke physicians to make these sorts of decisions in terms of initiation of rhythm control themselves? Or do we need better integration of stroke and cardiology teams within hospitals to help multidisciplinary decision making in those sort of contexts?
Well, I think that the multidisciplinary team is probably the best way forward at the moment. But I think as we collect more evidence, it may well be that we should intervene much more actively with rhythm control in such patients. But I think that the data is slim at the moment.
Okay, there will be more time for discussions after the official meeting. And now we will need to go on. And we have learned that we are good at preventing stroke and that maybe it makes sense to do this in screen-detected atrial fibrillation. But it's not just stroke. What else? Giuseppe, please.
Thanks for the invitation. What we know on AF and strokes is based on a large amount of epidemiological data. So for me, it's not easy to talk after John Cam. It's not easy to talk about something else out of stroke. So I started by considering not human epidemiology on AF, but the epidemiology of AF in dogs. And this is motivated. We are in UK. There is a large amount of dogs here in this country. They are also in the royal family, John, maybe you know. And so in the population of dogs across Europe, what is known also in the veterinary science is that dogs can have AF, but they do not develop stroke. They have intolerance to exercise, rapid breathing. In other terms, they have heart failure. And there is also an elegant study by Stanley Natel, who studied the thrombus related to radiofrequency ablation and atrial remodeling in dogs, and the result was that there's not a prothrombotic state. So in this model in dogs, the Virchow trial does not work as it works in humans. So some focus on heart failure coming back to humans, which is supported by many epidemiological studies. This is a study by Devin Conan, healthy women with new onset atrial fibrillation. So again, we go back to new onset atrial fibrillation. There is an important risk of developing heart failure for more than 4 times in patients with paroxysmal AF as compared to patients without AF, and 14 times more if we consider all the types of AF, also persistent and permanent. And many other epidemiological studies here at Framingham support the severity of developing heart failure after atrial fibrillation. Here the pattern, you can have any association, AF before heart failure together with atrial fibrillation or atrial fibrillation after. What is important is that if we have atrial fibrillation, the outcomes is much worse when heart failure develops. Here are data from the Netherlands. Let's consider in the tables the risks. Currently, with large use of anticoagulants, stroke declined in terms of incidence, but the incidence of heart failure is important. So this is a reality we have to consider. So we are at 20 years after this lecture by Eugene Braunwald, who stressed that heart failure and atrial fibrillation were the new epidemics. So going back to what we can do, this is the slide of the paper by John and Emma, surely among the adverse outcomes associated with atrial fibrillation, we have to consider also heart failure, and we have to be proactive. This is not easy because the links between atrial fibrillation and heart failure are multiple. There is a vicious circle. This is a slides of some years ago. We cannot go into the pathophysiological links, but we have to realize that nowadays we know much more. In the past, we used to consider atrial fibrillation as the result of valvular heart disease. This paper stresses that it may occur also the reversal, arrhythmia-mediated valvular heart disease. Atrial fibrillation may lead to a form of isolated atrial functional matter regurgitation. The mechanism is a bit complex. It's tethering of the posterior leaflet of the mitral valve. It's a mechanism completely different from ventricular functional matter regurgitation. We are used to consider it. So complex pathophysiology and data that support that this form of mitral regurgitation, which can also be severe, may be present in 7% of low atrial fibrillation, but in up to 50–60% of patients with heart failure and preserved ejection fraction. If the mitral annulus dilates along with persistence and worsening of atrial fibrillation, and on the right side of the slide, we can see that if during the follow-up there is maintenance or resumption of sinus rhythm, atrial functional matter regurgitation declines. Conversely, it worsens if AF recurs. And in the upper left, there's no time to make detailed comments, but in the upper left, the change in the atrial annulus dimension according to sinus rhythm or atrial fibrillation. So many ways to reduce heart failure by acting on AF, by acting early. The classical form of heart failure, which can be treated through control of atrial fibrillation, is atrial tachycardiomyopathy, which may be completely reversible form of heart failure. And indeed, in practice, we can have different combinations of left ventricular systolic dysfunction. In tachycardiomyopathy, all the dysfunction is due to atrial fibrillation, so AF ablation is absolutely indicated, the class 1 indication. On the other side, we can have LV dysfunction completely unrelated to AF. AF is just a base standard, and we can have intermediate forms. So variable relationship, but need to be active early in the phase of AF. This slides, again, from Eugene Braunwald, stresses the concept of atrial failure, something quite similar to an advanced form of atrial cardiomyopathy. As you can see in the picture, now in the center of the picture, there is atrial fibrillation. AF is at his side because the damage is so advanced that probably control of AF has limited benefit for the patient. And also in interpreting the result of AF ablation, we can consider that while ablation is effective also in reducing heart failure events, in heart failure with reduced ejection fraction, this is meta-analysis by Bill McIntyre and Jeff Ely groups, the same does not occur in heart failure with preserved ejection fraction. And we have to consider that in HFpEF, there is a large amount of atrial myopathy. We do not know if an earlier intervention could change the result. Now we can anticipate the detection of AF with wearables. This is an interesting study presented at last at Heart Rhythm 2023, non-controlled, but with loop recorders able to detect AF. This resulted in earlier intervention, and what is interesting is that heart failure hospitalizations declined. So an important observations. And also in the loop study, there is an important finding or reduced heart failure hospitalization by early detection and presumably early treatment of AF in this study. But what is interesting is that the benefit was age dependent. So there is always a time and a condition above that is a limit for our intervention. So early treatment before more advanced alterations. John showed a slide relating AF burden detected by devices and stroke. Here, a similar slide with increasing burden, increasing occurrence of heart failure. So again, a link that usually we do not consider too much, but is the basis for future intervention. This is my final slide. We have newly detected AF, a large variety of forms of AF, from subclinical AF, device-detected AF, paroxysmal AF. We have obviously as an outcome stroke. We have also worsening heart failure, but always there is the need to consider that AF can be a risk factor, but probably can also be simply a marker of risk. So need for more studies to distinguish what we can do in this setting. Thank you.
Thank you. And would you like to go and then?
It's up to you. It's a completely different topic.
Slightly different topic, but maybe also early treatment, place of LAA occlusion devices in screen-detected atrial fibrillation. Do we need to go on and every screen-positive individual gets an LAA occluder?
Yeah, we have not specific data. And I think what we can say is that in recent years, as you know, there was an increasing interest on left atrial appendage occluders. We have a variety of devices, and this is a list of the publications on PubMed. Many studies are observational. There are reviews and meta-analysis, and there is the need to improve our navigation between bleeding and thromboembolic risk. This is the navigation in between Sicily and Calabria, between Scylla and Charybdis. Somebody is proposing to have a bridge. I don't know if it will be practical or not. In terms of practical issues, this is an important paper chaired by John Cam, a practical guide on left atrial appendage closure for non-implanting physicians. Between one of the barriers for adoption of this treatment, this interventional treatment, is that many patients are not referred. So there is the need to make aware physicians who see patients who can have a substantial benefit by left atrial appendage occluder, to make this physician aware and to have referral. If we consider the evidence, a long debate about what is known about left atrial appendage closure. As seen before, the large amount of studies are observational, but the message is that there is a reduced occurrence of bleeding if we have a left atrial appendage occluder as compared to anticoagulants. And many of the patients cannot tolerate anticoagulants, and the indications is because of an important risk of bleeding. What happened in the guidelines in the last years is a transition from the 2B class to 2A class. The most recent guidelines as today are the American, we have a class 2A for left atrial appendage closure in patients with a contraindication to long-term anticoagulation. We will see tomorrow what will happen in the ESC guidelines. But an important table in the American guidelines is to distinguish when, in the presence of bleeding, there is an absolute contraindication to long-term anticoagulation, left column, and when, despite bleeding, anticoagulation is still reasonable. In few words, it is still reasonable when the condition that led to bleeding is curable. We have a transient bleeding. This is an important consideration. Among the many documents, let's consider this document from ERA, which strongly stresses that left atrial appendage occlusion cannot be routinely offered to patients who do not want to take oral anticoagulants or are non-compliant with their medications. This patient need counseling, detailed counseling, and in case a careful risk-benefit assessment and shared decision-making. Among the different conditions that put the indication to left atrial appendage closure, there are some for which there is a very strong consensus, an acceptable bleeding risk, ineffective anticoagulation, such in the case of stroke despite optimal coagulation, condition for which there is a strong consensus, and other which are more debated. Here a list. I will not go into details when to consider left atrial appendage occlusion. Anytime there is a history of recurrent major bleeding, bleeding disorders, some of them are congenital, cerebral microbleeds and or amyloid cerebral vasculopathy. The document includes a detailed analysis of all these conditions. Intracranial hemorrhage is a very strong indication. What happens in daily practice is that sometimes these patients are not referred to the centers who can provide the implant of the left atrial appendage occluders. Cerebral microbleeds due to small vessel disease is a cause of important risk of cerebral bleeding. Major gastrointestinal bleeding, ischemic stroke that occurs in patients with oral anticoagulants, again, a condition which could benefit of the implant and continuation of oral anticoagulants. What is important and is stressed in the document is that the risk of complications, acute and early post-implant complication, is low. Sometimes it is perceived as higher than what it is actually reported and detected in practice. One important point is what type of antithrombotic therapy is needed after implant of the left atrial appendage occluder. We started with a heavy treatment, anticoagulants, clopidogrel, aspirin. Now we are moving to much simpler approaches, aspirin or clopidogrel together, or also aspirin or clopidogrel, and there is also the perspective of low dose DOAC. This is a very interesting field of research that will simplify the management after the implant. So the conclusion in general is that left atrial appendage occluder is an effective strategy, able to prevent thromboembolism in patients with contraindications. There are no large RCT. Accurate selection of patients with shared decision-making is needed, but it's a safe procedure with low rate of complication, and antithrombotic therapy is needed and with different regimens, and probably we will have new knowledge in the future. What about AF detected through screening? And AF screening as an international collaboration started with the target of promoting screening in order to detect a symptomatic AF. Few words. If we have clinical AF, which is asymptomatic, we know there is absolutely no difference in stroke risk, and we have screening targeted to detect high burden clinically asymptomatic atrial fibrillation. So in general terms, for screening, single time point screening, the screening that we practice, usually what is the place of left atrial appendage occlusion? I would say it should be considered for any clinical AF, symptomatic or asymptomatic, with the same indication for left atrial appendage occlusion that are in AF, which is symptomatic and detected in other conditions. This is an important paper by Ben Friedman. What is the risk of ischemic stroke in screen-detected AF when not anticoagulated, red line, or in clinically diagnosed AF, right picture? It is absolutely the same. So we have to consider that the risk of stroke is the same. If the patient can't tolerate anticoagulants, we will prescribe anticoagulants. If there is a very high risk of bleeding and bleeding with anticoagulants, we have to consider left atrial appendage occlusion. Among the wide spectrum of AF that we can detect nowadays with devices, this is a picture of Ben, an excellent picture. When we go to the right side of the slide, as stressed before, the risk of stroke is lower, and we will have to manage the treatment accordingly. In the left side, single time point screening, the stroke risk is high. What to expect in the future? This is an important paper by Chris Gale, who is with us today, showing that the incidence of stroke along the time declined in UK in parallel with an increasing awareness on the importance of AF, an increasing use of anticoagulants, a lowering of aspirin, which was inappropriately prescribed to prevent stroke. We hope that this decline will continue, and probably we have to consider that the way to approach is to use anticoagulants or even left atrial appendage occluders when needed. Thank you.
Thank you, Giuseppe, for also including this area of LAA occlusion. I think we need to go on now with the next talk. So thank you for your overview. And Maria-Lisa, you will tell us about, oh, not from Canada, but far away also, so from northern Norway, from Tromsø, long-term PI of the Tromsø Heart Study, and also interested in athletes, so AF in master athletes. Maria-Lisa, please.
Thank you very much for having me. I'm just waiting for the presentation.
Okay, the presentation will be shown here.
Thank you very much for the invitation. So yes, I'm from Tromsø, Norway. And I will present some results from atrial fibrillation in master athletes from Norway mostly, based on the Tromsø study and the Birkebeiner aging study. So this is what I'm going to talk about, the definition of a master athlete. I didn't know, so I had to ask Ben. I'll show you his answer. And then a little bit about physical activity and exercise in the general population, AF in male master athletes, and then in female master athletes. Screening, should we do that? And then conclusion. And then I want to thank my expert colleagues Bente Morseth and Marius Myrstad for sharing slides and ideas, and to the Norwegian Atrial Fibrillation Research Network. We are doing, these are some of the group members. We are doing a lot of AFib studies there are at least 3 ongoing RCTs, 2 of them in athletes actually, and also we have a large national population study screening population for looking for undetected AFib. It's called NordScreen. You haven't heard about it yet, but I can see the PI as a new member is sitting down there, Sigrun Halvorsen, so I think I had to mention it. But I'm going to talk about the master athletes. So in Wikipedia, they are defined as a class of the sports of athletics above 35 years of age. And Ben, he said, well, master, I think of us older athletes, often much older than 35, who continue to compete at high risk levels, but could also include cycling, not only track and field. So I was then thinking about myself and our Norwegian studies. So usually we include, we call it veteran athletes, and they are usually above 65 years, just like me. So this is one of the first papers on physical activity, exercise, and AFib that we published in our group in Tromsø study in 2016. So it's based on the population of Tromsø, more than 20,000 adults in the population study, followed for 24 years. And we found this J-shaped association between physical activity and AFib. You have heard about it, but we were the first to show that this was also true for women, not only for men, because we included actually both sexes. So, and then we, together with some other European colleagues, we published this review article a couple of years later, discussing different AF mechanisms for the association with atrial fibrillation in moderate versus light versus no exercise at all versus hard physical activity. So then, almost at the same time, in the other part of the country, Marius Myrstad was doing this study among the Birkebeiner National Ski Race participants. So it's an annual ski race, 54 kilometers, more than 1,000 meter uphill altitude meters. And he's one of the participants, of course, himself. But he was interested in the older participants, the master athletes. So he, based on the membership register, he sent a questionnaire to the older participants who have participated up to 14 times on this race during up to 40 years, and asked them about atrial fibrillation. And he found this J-shaped curve again in this cohort. So then he needed a control cohort, and that he wrote a letter to me in 2014 and asked for collaboration, and I could provide a control cohort from the Tromsø study. So after that, we have been collaborating on these athletes where we have provided the control. So yeah, so I will show you a few of our results. First in male. So here to the left we have the veteran skiers, and then to the right we have the general population from Tromsø. They are all around 70 years, and you can see that the AFib based on self-report is maybe it's a little bit higher among the veteran skiers, at least not lower. And then a couple of years ago, one of our PhD students in Tromsø published this paper based on the Tromsø study and comparing the Birkebeiner aging study, which are the master athletes. So it's about atrial fibrillation and stroke among these older men exposed to prolonged endurance sport practice. The median times of participating in the Birkebeiner race was 14 times. The guy who had the
done most races, had done 53, I think. And the oldest man was 90 years old. Even my father, he started to participate in this race when he was 67 and participated 10 times. So, then here he found this relationship between risk of AFib and being very vigorous athletic. So the risk was highest in the veteran athletes, as you can see to the right. And then he also looked for stroke in this cohort. And as you can see here, the risk of stroke was higher among the veteran athletes compared to, with atrial fibrillation compared to the veteran athletes without atrial fibrillation. But the risk of stroke was lower among the veteran athletes compared to the general population with AF. So the last paper from this male cohort was published last year, also with one of the same PhD student, Kristoffer Johansen, and it's about mortality. And what he found that those who are veteran athletes have much lower mortality compared to all the other groups here. So physical activity prolongs life. Physical activity on a master athletic level prolongs life. And then there are not many studies among female endurance athletes. But we have this paper that was published last year, comparing the male to the right, in blue, and the females to the left. And as you can see, even in the 46 female athletes, there is a larger risk of atrial fibrillation among these athletes compared to the general population from the Tromsø study. This difference is not significant. We think it's a power question. Yeah. But we are collecting more female athletes, so we will see in the future. So should we screen for AF in master athletes? Sports cardiologists, they promote cardiac screening among athletes to prevent sudden death. They are not so interested in AFib. But AFib is much more common than sudden death in master athletes. So master athletes with AF have less stroke than non-athletes with AF, but more stroke compared to athletes without AF. So if they're going to screen to prevent sudden death, maybe also screen for atrial fibrillation? Question mark. So the conclusion is that the master athletes, participants in the Scandinavian cross-country ski endurance races, they're not only Norwegian studies, also Swedish. They have more atrial fibrillation, but less stroke than not athletes with atrial fibrillation, and they live longer than non-athletes. Thank you very much.
Thank you. Maja-Lisa, stay there. There's time for one comment, and I think, Ben, you wanted to raise a point.
Just that in Australia there is an unpublished study of a lipidomic biomarker, Andrea Lugersh and Julia McMullen. This biomarker is strongly related to the presence of atrial myopathy and a PI3 kinase that's related to atrial myopathy. It predicts in master athletes who will go on to get atrial fibrillation. I think that it's really quite interesting because not all master athletes get AF. So which ones go on to get an atrial myopathy? That's really interesting.
That's what they always ask us about. How do I know if I am at risk? So, and I saw it was on your list, your wish list for future white papers. Yes.
Thank you, Maja-Lisa.
Our next speaker is Bill McIntyre, who on his behalf and Jonathan Mant's behalf will talk on an update on the continuing screening RCTs.
Perfect, thanks so much. I think Jonathan actually has, some of his own slides to go after. Friends, I think we know that the way to really move the needle in this field is to do randomized trials to remove all doubt. And as much as we talk about atrial fibrillation, we care about atrial fibrillation because of all the bad stuff it's associated with, and perhaps the worst of that is stroke. And that's why a lot of what we've been doing is working towards finding a way to collate all of the wonderful efforts that people from across this room and across the globe have been doing to try to harness the power and get that data together. So I wanted to give you a snapshot kind of where we are, what's coming, what's immediately imminent, and what's in the future. And then Jonathan's going to show some specific deep dive stuff on SAFER. So this shows what we published in 2022 as a group. We did a systematic review of the existing literature, looking at trials that screened for atrial fibrillation and measured the ability to reduce stroke. It's intentionally simplistic, and that diamond in the middle over there borders right on the 0.99 confidence interval, meaning at the time, the totality of the evidence suggested, yes, it was possible to reduce stroke through screening of atrial fibrillation. We did some stuff with trial sequential meta-analysis, which I'll come back to at the end. And then, of course, following that, many members of this group contributed to a protocol for an individual participant data meta-analysis that in many ways is sort of the child or the eventual product of one of the work packages of the EFFECT EU grant that Renata led. I'm going to skip that. These slides are from Soren Diedrichsen. These basically show an inventory right now of what's sitting in the individual participant data meta-analysis database in Copenhagen. There's a number of studies there on the left with about 62,000 patients. They're not all randomized, but they all do have valuable data. And then some studies that came in after. There's additional studies for which there are agreements. We're just waiting them to finish up, including Stroke Stop that's coming soon and SAFER. In totality, hundreds of thousands of individual participants will contribute data to this initiative. If for some reason you've got a project that works, that is not an agreement, we're always interested in it. It's just an oversight that we haven't heard about it or talked about it yet. So please do let us know. Here's what's coming soon, because there's two huge trials being presented this weekend. So on Sunday, September the 1st, there's presentations first by Katrin and then by Renato. Greg is giving a 2-for-1 deal as a commentator, and he looks like he'll wrap them both up. If you want to add that to your agenda, that's probably the biggest item of the conference. So first, GUARD AF. So this is a trial that ultimately had its trajectory altered by COVID, a relatively simple trial in the United States of America, randomization of patients that had no AF and over the age of 70 to either have a 14-day Zio patch or not, and the primary outcome of this is stroke. Now, we actually know a little bit of what they found because they told us in 2022 about their data on AF detection. And I've circled it there in red. 4.5% of patients overall had atrial fibrillation detected. That was made up by about 4% with paroxysmal atrial fibrillation and 0.5% with a 100% AF burden that could be persistent or permanent depending on how you look at it. And this slide here just gives you an idea of the percent time in atrial fibrillation, since we're all now so interested in atrial fibrillation burden. And then, of course, Stroke Stop 2 in the same session. Katrin will present this. A little bit of a different design. In Stockholm, everybody aged 75 and 76 was invited to screening. They either said yes or they said no. And ultimately, the goal here was stroke or systemic embolism with a very interesting intention to screen design. Remember, everyone was invited. The big difference in this study between the way the groups is that there was first a stratification based on what your baseline BNP was. If it was low, they took one quick look and that was it. If it was high, that was more likely to go along with atrial fibrillation, so you did atrial fibrillation for 2 weeks intermittently. And the stroke stop group has also already told us a little bit about how much atrial fibrillation they found. If you work through this ladder diagram that separates out the control group and of course the intervention group, pulls off the people who didn't accept the invitation, the people who already had atrial fibrillation, and then stratified at the very end in the red box you see, interestingly, almost the exact same proportion as the other study, 4.4% of that group had atrial fibrillation. So we'll see how that translates into stroke outcomes. And then, of course, it's important to look at some of the really big work that's in progress out there to move the needle. So I thank Paul Heidenreich from the US VA for the slides on Valiant. So the VA here stands for Valiant. That's the Veterans Health System in the United States. So the goal here is to use, again, a patch-based 14-day ambulatory EKG. And basically, they're looking at a composite of all the bad stuff that can happen with atrial fibrillation. Stroke, major bleeding, heart failure, myocardial infarction, or all-cause death. They're enrolling patients who are at least 65, have a CHA2DS2-VASc score of greater than 3. They have 24,000 patients total intended, with a goal of a 1-to-1 randomization embedded within the US VA system and Medicare follow-up. So their primary endpoint, again, is this composite of hospitalization for stroke, embolism, heart failure, MI, bleeding, or all-cause death. And then they're pulling apart secondary endpoints like the diagnosis of AF and the physician behavior. They're planning to follow up for 3.5 years. And I believe Paul is here now if you have questions about that. And then Axel Bauer kindly provided me with slides on the Austrian Digital Heart Study, hot off the heels of eBrave. They're looking to move the needle on stroke outcomes again in Austria this time. So these are folks who have health insurance in Austria, 65 years or older without known atrial fibrillation. And then basically the randomization is to usual care or a digital screening and intervention. The first patient's supposed to go in next year, and this ambitious study is aiming to get over 100,000 participants. Then finally, where are we going as a field overall? So I have this graph on the left, this is called trial sequential meta-analysis. And if you've been here for a week like I have, it starts to look a little bit like the tube map when you stare at it, I think. So the idea here is when we do trials, every time you update statistically to say, have we reached the point where another trial is not going to move the overall body of evidence? So to date, I've circled in red, there's about 36,000 patients randomized to AF screening or not that have stroke outcome data. And the optimal information size, as you see above it, is about 100,000. So when we have around 100,000 patients, we might be at the point, just based on the priors of the data, that additional trials might not move the needle. Of course, these are all projections, and a lot of heterogeneity comes into this. I think we all can agree that a handheld BNP-guided screening trial is very different than a 14-day patch ECG, or maybe not. Only Greg knows right now, I think, right? So where we are in terms of the data right now, in just a couple of days, we'll be up to 76,000 patients in totality, and the other large efforts that are going on are going to take us up over 300,000. So I conclude to say that randomized trials really are the best way and the only way to move the needle on AFib screening. To date, we only have 35,000 patients in AF screening RCTs with stroke outcomes. That's going to double over the weekend, and ongoing efforts will more than triple that number. And I'm so excited to be part of this group here that really is bringing forth the collective effort to move that needle for our patients and for our systems. And one of those big trials, of course, that's going to help move that needle safer, which we've heard a lot from, and I'll turn it over to Jonathan to talk about that.
Great talk. Thank you.
Right, so I see that the time I have
minus 2 minutes, so I will be very, very quick on this. I think I've missed the, yeah. So that the SAFER trial, Bill is right in it does have about 100,000 people overall, because there was a pilot trial that will be included in the main trial results that had another 14,000 people. So there's the design of the trial, using the Xenocor device that was elegantly described in the trial for detecting AF in rheumatic heart disease. So far, we've closed a recruitment with just under 90,000 people to the main trial, recruited from 197 sites. We nearly finished randomization. Our interim process findings are as we would have expected. But pleasingly, we've only lost 20 devices, which is pretty good out of all that screening. So the people post the devices back after they finish using them. So I think that's pretty good. And there are our timelines. I'm just going to give you a few headlines on sort of interim things that we've been finding out along the way. So you'll see there are two colors on these, the top two graphs. One has remote, one face-to-face. When we started the program of work, it was in the pre-COVID work, so we assumed that people would have screening done in their general practices. And that's what we call face-to-face. Then COVID struck, and the trial has been done under circumstances of remote screening, where the devices are all posted out. And you can see that uptake of screening was not affected at all by the fact that it was done remotely. Neither was the quality of the ECGs that were obtained. The bottom left slide shows the AF detection rate and anticoagulation rate. So high anticoagulation rates obtained at all ages, and as one might expect, the detection rate for AF shoots up over the age of 85 to over 9%. And consent rates hover around the just under 50%, but fall off, as one might expect, in people over the age of 85. While we were doing the so switching to remote screening, we weren't sure whether it would still need to be operated by practices or just by central administrators. And essentially, this slide shows that doing it via the practice didn't really make any improvements of importance compared to doing it by central administrators, which is important in the British NHS, and it means that you can kind of do the screening with really very little clinical input whatsoever. We looked at the reliability of the single lead ECG interpretation, and essentially the bottom line is that the agreement is only moderate, and the biggest determinant is the quality of the ECG signal. So I think that links into a lot of other things we've heard today about sort of the potential role of AI and machine learning in improving ECG signals. It can also obviously improve the interpretation prior to going to a manual overreader. Therefore, we looked at the quality of the ECGs done over time. Patients in this trial had the ECGs for 3 weeks. The vast majority of people, all their ECGs were really of acceptable quality. For the proportion of people that had very poor quality ECGs, we wondered whether we ought to intervene. So, and our trigger was if they had over 25% poor quality ECGs in the first 10 days of screening. But we found that their quality improved whether or not we gave them any training or not. So basically, if people use the devices for long enough, they get better without any input from us. We've heard about other aspects of potential harms and why people take part in screening or not. We've had a couple of papers looking at this. Firstly, why people take part in screening. They're the sort of things I think that you would expect. Though they were slightly judgmental about the people that didn't take part in screening, but that's an interesting aside, really. And they didn't really recognise any harms of screening, though they acknowledged that it might make other people anxious, but not themselves. In terms of people who didn't take part in screening, I think the because of the age population, you can see that within the very old people, there's a feeling of lack of utility. And so I think while screening can be offered to this group, it clearly needs to be a patient-based decision. So in terms of conclusions for other sort of AF screening programs, you can include people up to and over the age of 85. The screening process can be done with really very minimal engagement of clinical staff. I think there are all sorts of strategies that can be done to improve the reading of single lead ECGs, and participation in screening should be an informed decision. Thank you.
Thank you very much. Any quick points or questions for Bill or Jonathan? I think we probably said enough then. But Renata will have some final words for us.
Yes, but before I close this session, I need to say that there is a group photo planned. Is it outside? Ben, you
No,
have
it'll be inside, but as soon as we stop talking and stand up, people who are at the back will move some of the tables to leave a gap, and the photographer will be up there, I understand, there, and we'll take a picture of people in the gap. So this will be our group photo, which we've done annually whenever we've met together, and no exception this time.
Okay, and with that, I would like to close this very interesting, multifaceted meeting again. AF Screen, you said it started in 2015, and every now and then Ben comes and asks, is AF Screen needed anymore, or are we done? But AF Screen set out to promote screening for atrial fibrillation to prevent stroke and to show the evidence for this. And as you have heard in particular from the last talks, there is not the final evidence yet. And when, with all you experts from different fields digging deeper into this field, we saw that there is more granularity to it. We see there is different types of screening, there is different settings of screening post-stroke. We have new types of screening and new atrial fibrillation types, device-detected atrial fibrillation. You have defined the term recent onset atrial fibrillation. We have new tasks and new projects with the white papers for the next year and the years to come. And so I'm very much looking forward to further discussions, networking after this meeting, and in particular to the 10th anniversary meeting next year. So thank you very much for participating and have a great conference.